Welcome. I think students were able to see what I am writing. Fine. So they're able to see, right? Yes. Thank you. Thank you, Alex. So he gave the consent that he is able to see. Okay. If you're ready, we can start. Ready? Ready. Okay. Okay, let us start. I think we have been discussing on the definition of NSVT. So NSVT is non-sustained ventricular tachycardia, and SVT, sustained VT is something different, where you have the VPCs that are going to last for more than 30 seconds is what we refer to as sustained ventricular tachycardia. We know that. And apart from that, we have many other things, right? Like we know that AV dissociation is one of the important features of VT, and gross axis change is going to be one of the important features of ventricular tachycardia. And apart from that, if you really want to know that there are some other classical features, NSVT means non-sustained VT, non-sustained ventricular tachycardia, and don't think it's non-supraventricular tachycardia, something like that. It's a non-sustained ventricular tachycardia. It's called as basically NSVT only. That's a term that's used in books also. So then we have the third point. So other points that favor the diagnosis of a ventricular tachycardia. A lot of points are there. But let me tell you certain important things. Suppose you have something called a Brugada sign. You have something called Josephson sign. And you have something called Verreki's AVR sign. And of course, we have the rabbit ear sign. So where to use this are the most important. So I told you only few things because there are a lot of more information that you need to know if you want to really diagnose a ventricular tachycardia. But this four, I think, is very commonly asked in exams. This Brugada sign, this Josephson sign, this Verreki's AVR sign, and we have something called a rabbit ear sign. Okay. So what do you mean by Brugada sign? So Brugada sign in the sense like whenever you have kind of a QRS kind of a morphology. So from the beginning of the QRS to the nadir of the S wave, to the nadir of the S wave. This is called the nadir of the S wave. From the beginning of the QRS to the nadir of the S wave, the distance that we are seeing. So this is the starting point of the QRS, is the nadir of the S wave. So if this distance, if it is more than 100 milliseconds, so that is likely to be a ventricular tachycardia according to many researchers. So that's what we call as a Brugada sign. And we have something called a Josephson sign. So what do you mean by Josephson sign? Josephson sign says that when you have a RS complex, like this, you have R and S. If the S is notched, so we have an R, we have an S. If the S is notched like this, so this notching of the S wave is very specific for ventricular tachycardia, and that's what we refer to as Josephson sign. So notching of the S wave, like in an RS complex, that's Josephson sign. Then we have Verreki's AVR sign. What do you mean by Verreki's AVR sign? Verreki's spelling is Vereckei. So that's what we refer to as something called a Verreki's AVR sign. So in AVR, you will be seeing a fully positive complexes like this. Something like this. I want to draw a little better. So you have a fully positive R wave. Maybe the concordance may be opposite, doesn't matter. So if you see a fully positive complexes, so usually this indicates an extreme axis deviation or probably a northwest axis that we're talking about. So this is equal to VT most of the time. So this is Verreki's AVR sign. And at the same time, if you see something like this, for example, you're seeing something like this. So this kind of AVR, even though you can argue that it's some positivity seen in the AVR, and this kind of things, you should not think about a ventricular tachycardia. This kind of stuff usually seen in the setting of probably some other condition that produce probably a little right axis deviation. Like for example, TCA poisoning. So you can see this kind of AVR positivity will be there, but still it will not be a full-blown AVR positivity. Maybe a little positivity may be there, and this should not be confused with a ventricular tachycardia. If it's a ventricular tachycardia, it should be a full positivity, or otherwise you refer to as the initial R wave. Initially, to start with itself, you have the R wave. So that is what we are going to talk about. A ventricular tachycardia is equal to VT. That's what we call it as a Verreke's AVR sign. Then what do you mean by rabbit ear sign? So this will be applicable if the patient is having a right bundle branch block pattern. If you have an RBB-like pattern, in that usually in RBB you will have this kind of M-shaped morphology. So there are two types of M morphology that is possible. Even you can get an RSR pattern. Remember, this kind of typical RSR pattern is unlikely to be a VT. So most of the times you don't get. So this kind of M patterns you get in V1. If it's a right bundle branch block, we know that. So in this, which is surely a VT? Can anyone tell which is considered surely to be a VT? Either 1 or 2, which is considered to be a VT? Which can be surely a VT? 1, 2, which is VT? This is surely a VT. Of course, this is 100% a VT. Why I'm telling it's a VT is because when you have a taller left rabbit ear, so this is called rabbit ear sign, which means this looks like a rabbit ear. This is a left and right. If you have a taller left rabbit ear, it's surely a VT. Suppose if you have this kind of picture, it may be a VT. May or may not be a VT. I'm not telling that it should not be a VT. But this is very likely to be a VT. That's what I'm trying to tell. So high likelihood for VT if you have a taller left rabbit ear, if you have a right bundle branch block like pattern. Apart from that, many other criteria are there. Like these 6 are the most important, but more than this, you have so many things to tell that it's a VT. Like that's why I told you VT can be diagnosed, but SVT with aberrancy cannot be diagnosed. I mean, you want to know the reason. Reason is so much is there. If you really want to know the reason, you see something called an RSR pattern, but I don't want to really tell. If you have an RSR pattern, you know the initial R wave has to be small in a true right bundle branch block. Initial R wave in a true right bundle branch block, it should be small only. Why? Because this is septal wave. So in a ventricular tachycardia, if it comes from the ventricles, it cannot be small. The initial deflection cannot be small and it will be very big. So that's the reason why we feel that it's likely to be a VT. So, I mean, if you want to tell in a simple way. So like this, you can tell explanation for everything, but I don't think it's needed, by the way. So this is how you diagnose VT. These are the algorithms based on electrophysiological studies they have made it. But remember, there is not even a single algorithm that can concretely rule out a VT. All the algorithms are basically known to diagnose the VT. But there is no algorithm that can concretely rule out a ventricular tachycardia unless and until you have a clear-cut evidence, as I told you, of the previous ECG of the patient, which shows the left bundle branch block or a right bundle branch block, and the patient with current tachycardia also has the same pattern of left bundle branch block or right bundle branch block without much axis change. Then you can diagnose a SVT with aberrancy. Otherwise, if you do not have a previous ECG, then it's very difficult to rule out a SVT with aberrancy. It's better always to diagnose a ventricular tachycardia, as we discussed already. Apart from that, these are the exam questions. So we had the, like AV decision, gross axis change, Brugada sign, Josephson sign, Verreke's AVR sign, rabbit ear sign. But apart from that, there are some things which are away from the exams, which have not been asked yet. So in that, we call it as absence of RS complexes. Absence of RS complexes in precordial leads. In precordial leads, which means, what do you mean by absence of RS complexes? Which means that is equal to concordance of all complexes in V1 to V6. What do you mean by concordance of all complexes in V1 to V6? Which means either the VT will be like this or the VT will be like this. So both, if you see in a realistic way, it won't be any different at all. So what I'm trying to tell is, here you will not be able to make RS complexes at all. So you can consider this as an R or you can consider this as an S. So it doesn't matter. You can't really make the concordance or the discordance here. So this is what we mean by absence of RS complexes, which means concordance of all the complexes. You can't really tell R and you can't really tell S. Either you can call it as an R or you can call it as an S. but you can't really see something like this. So this is what we called as an RS. Or if the patient has like this, in this you can find out an RS, not a problem. Or the patient is having something like this, so then this is a QR complex. So you can, this and all will not come under this. But if you can't find which is R and which is S, so you can't differentiate really. This is called as concordance, and this is a very important sign of a ventricular tachycardia. So that's concordance, absence of RS complexes in all precardial leads. In fact, this is one of the first criteria according to the Brugada's criteria for diagnosing ventricular tachycardia. But anyways, no need to know about Brugada's algorithm. You will be otherwise very, very confused. And if you find an RS complex, somewhere in any of the precardial leads, this is the less value, but still this is very useful. If you see anywhere this kind of RS complex, if you take from the R wave to the S wave, if it is more than or equal to 60 to 70 milliseconds, this is suggestive of VT again. This is present in the Brugada's algorithm, but remember this is not equal to Brugada sign. Brugada sign, the value is different, even though things may look a little same, but the value is different here. It's 100 millisecond. But if that is not satisfied, then if it is at least more than RS, like if you have a clear-cut RS kind of a thing like this, and in this, if you see more than 62 milliseconds up to the nadir, then again that is also suggestive of a ventricular tachycardia in this setting. Similarly, if you see some kind of atypical bundle branch block morphology, atypical bundle branch blocks, like it could be atypical RBB or atypical LBB. So in that setting also you can diagnose a ventricular tachycardia. For example, what do you mean by atypical bundle branch block? So if you have a left bundle branch block, we know in V5 and V6, strictly no septal cues. These points will be coming very handy now, because yesterday we discussed there should be no septal cues at all. If it's a left bundle branch block, absolutely no septal cues in V5 and V6. Suppose if I'm seeing a QR kind of a pattern, it's a white complex tachycardia, but I'm seeing a QR pattern like this. I mean, I'm drawing a little affazat, but I'm talking about something like this, QR morphology like this. So if you see this kind of a Q wave, this is a QR morphology, and this is unlikely to be a left bundle branch block. So that's a kind of an atypical left bundle branch block. So it's not a true left bundle branch block. So this kind of pattern, if the patient comes when you have a atypical bundle branch block morphology, then again, that must be usually a sign of a ventricular tachycardia. And apart from that, so atypical bundle branch blocks, if you see QS in V6, either it could be whatever may be the bundle branch blocks. If you see QS in V6, it could be like this or this. So this like this. So if you see this kind of a QS kind of a morphology, this is what we refer to as QS, which means this is a single negative wave like this. If you see this kind of a QS morphology in V6, then again that is diagnostic of a ventricular tachycardia. Like this, you have so many points to tell. And do not forget the clinical history. The clinical background that can strongly tell you that whether the patient is having a VT or not. Like the first clinical background, history of a prior myocardial infarction, history of having a ventricular arrhythmia, or if the patient is having not only MI in any ischemic heart disease, history of having a heart failure, or patient is having history of cardiomyopathy, or the patient is having his family history of sudden death, or patient is a known case of structural cardiac problem like HOCM. So you have to know the history properly. So usually, if history suggestive of some abnormality like this, then again, usually I'll be thinking about a ventricular tachycardia only. I'll not be thinking about anything else apart from the VT. So these are the points to tell that generally which favors a ventricular tachycardia. So in that, whatever I told you in the beginning, AVT session, Brugada, Joseph sign, Verrecki, Rabitier sign, Gross axis, all these things have been asked in exams. But the remaining things have not been asked in exams, but still it is really important. In that, I feel the most important is the first one, that is the absence of concordance in your precardial leads, which means I mean absence of RS complex, that is presence of concordance in all the precardial leads. Like you can't be able to really tell which is R and which is S. And either in one way, if you see it look like an R, in one way, if you look, it might look like a S also. So this kind of things is going towards a diagnosis of a ventricular tachycardia. So, but how will you localize a VT? Is there any point to localize a VT? So VT can originate from many places. So to localize a VT, so first of all, I need to know first whether it is coming from right ventricle or left ventricle. To answer this question, this is the first step I have to answer. So to localize, the first step is whether it is RV or LV. So I will answer this question, RV versus LV. You know that, isn't it? How to localize RV versus LV? You're going to see whether it's a left bundle branch block or a right bundle branch block. So if you have a LBBB morphology, we know that it's right ventricle. If you have a RBBB morphology, we know it's coming from the left ventricle. Fine. Second is to tell whether it is anterior or posterior. So here your previous knowledge of LFB and LPFB will be helpful. So as I told you, if you, in this condition, you see this is seen in V1. So V1 is the one you're going to see for predicting RBB versus LBB. Suppose if you see 2, 3 AVF, if you're seeing negative complexes, so which means, you can remember in LAFB, you used to see RS complex like this. RS means it's predominantly negative complex. So that is sign of a left anterior fascicular block, which means that the sign of a posterior conduction in an anterior fascicular block causing a negative complex in 2, 3 AVF. So which means this is a posterior conduction, which means it's a posterior surface origin. So if the 2, 3 AVF is positive, it must be anterior or probably even an outflow tract VT. Anterior outflow tract VT usually will be having a positive 2, 3 AVF. So that knowledge about the left anterior fascicular block will be helping you here also to tell. When there is a, Alex is asking, when there is a concordance in precordial leads, can we say it as RBB or LBB morphology? That's why I told you, whenever there is a concordance in precordial leads, which does not tell you a particular morphology, it is VT, that's all. You can't tell RBB versus LBB, right? If there is a concordance. If you cannot tell which is R and which is S. That's simple. Then that's the reason why you call it as a VT in the first place. But this last thing would be narrow QRS too. No, I'll come back to that. We are not really talked about narrow QRS. We'll talk about narrow QRS later on. In that case, there is no need to localize, for example. So in that case, it will be very extreme emergency. You don't really need to localize in the first place if there is a typical concordance. Even though there is a concordance, usually there will be some evidence of this kind of things from using other limb leads also you can find out. We are talking about only the chest leads inside of concordance. Anyway, anterior versus posterior 2, 3 AVF, if it's positive, it is mostly posterior origin, and if it's positive, it could be anterior or outflow tract origin. Then the next thing I have to tell whether it's coming from apical area or basal area. So in that setting, I'll be seeing 2 leads. One is the AVR and second is the V4. So this is apex, this is base. So AVR is this area, apex is this area. So apex is here, AVR is here. Base is here, apex is here. So I'm taking V4 and AVR. So if my VT is originating from the base, from the apex, it will be originating, it's going towards this side. So towards the base, it will be going. That's the usual thing. If it's originating from the base, that is, the heart is from the base, it will be moving towards the apex. So which means if AVR positive, V4 negative, I can tell this VT is originating from the apex. If it's otherwise, if AVR is negative and V4 is positive, is going towards the apex from the base, means I know it's originating from the base. That's also, I can tell VT whether it is originating from the apex or the base. Then fourth, finally, I have to tell whether it is coming from septal or lateral, because it's a 3-dimensional thing, isn't it? Heart. So you need to tell. So now we told apex, base, then we told anterior versus posterior, then septal or lateral, which area it is originating from. In that, your 1 and AVL will give a very good clue. Suppose if 1 and AVL is positive, then I can tell it is septal, and 1 and AVL is negative, very likely to be it is originating from the lateral area. Very likely it's originating from the lateral zone. If 1 and AVL is negative, it is likely originating from the lateral zone. In the same time, many of the times 2, 3 AVF, if you see, septal will be negative and lateral will be positive. Usually, most of the times if it's originating from the septum, 2, 3 AVF will be negative, and if it's originating from the lateral zone, 2, 3 AVF will be positive. So, let us localize a VT first. I mean, I'll tell you that this is a VT. Let us try to localize it first. Okay, just try to localize it. I'm telling you it's a VTO. Overall. So try to localize it first. What you're seeing? You're seeing RBB pattern or LBB pattern. You're seeing an RBB pattern, of course. And in this one characteristic, finding of VT is there. What is that characteristic finding? What is that characteristic finding? Can't you see the taller left rabbit here? Yes, can't you see the taller left rabbit here? So that is sign of a VT, isn't it? So it must be a VT. So it's originating from the left ventricle, of course. So then whether it's originating from the anterior or posterior, that's the next question. See 2-3 AVF. 2-3 AVF positive or negative? 2-3 AVF positive or negative? 2-3 AVF positive, which means it's originating from where? Anterior or posterior? Anterior. So very likely it will be a anterior outflow tract VT. So it's a left ventricular outflow tract VT, very common, which means it's originating from the outflow tract very commonly. Apart from that, it's originating from the base or the apex. It's not originating from the base or the apex. Okay. AVR is negative, V4 is positive. So where it should originate from? Where it should originate from? Base or apex? Yes, of course it's originating from the base. It's very clear because outflow tract, it should originate from the base of the heart. So base. Then finally, to tell whether it is septal or lateral, where? You see the 1 end AVL. 1 end AVL is negative or positive? 1 end AVF is negative or positive? Of course, 1 end AVF is negative. So if 1 end AVF is negative, it is coming from the lateral side. Clear? So what I'm trying to tell is this is a left ventricular outflow tract ventricular tachycardia. Outflow tract tachycardia that is very likely originating from the base of the heart and the lateral portions of the myocardium. This is the diagnosis of the ventricular tachycardia. This is how you localize a ventricular tachycardia. If you really wanted to localize, even though this is not important, this gives some sort of at least a basic to tell how and where the ventricular tachycardia is originating from. AVR is positive in the third column. Where in the third column? This is AVF actually. This is AVF, this is the AVR. I think it looks like AVR because of the QRS complex that is merged with it. That is not AVR. This is the AVR. Here AVR is not positive. This Verrecki sign is not positive here. Here it is having this kind of pattern that I won't take it as a positive. So it's a negative wave only. So I think this must tell you how to localize a VT. So that must complete your confusion. So this is how you localize a VT in case if you want to localize a ventricular tachycardia. Understood or not? Clear? Third, we'll move on to diagnosis of tachyarrhythmias algorithm. Josephson sign is all about number. Rabbit ear is not about numbers. Rabbit ear is about the morphology that we are seeing. Josephson sign is the duration that you're going to see. Both are completely different. Cannot equate rabbit ear and Josephson sign. Oh, sorry, Josephson. I thought the Brugada sign. Josephson sign, you're talking about notching. No, in the sense, Josephson sign is you have a RS complex like this. You're having an RS complex, and you're having an RS complex. And if you're having an RS complex, if you have a notch like this in the beginning. So remember, if you have this kind of pattern, this is something different. And this is something different. So this is a clear-cut notch. I mean, when you start with in the S wave typically. So what I'm talking about is if you have a rabbit ear sign, you're not, I mean, this is not a notch actually. This is something like a ventricular depolarization that is creating that kind of a notch. So that is completely different from Josephson sign. It's not the same. Both are completely different. The S wave, if it produces notch, that is different. If the R wave that produces notch, that is different. And to tell it's an S wave, you should have a negative form like this. Without that, how can you call this as an S wave in the first place? I mean, if that is your doubt, I don't understand your doubt. If that is the doubt, then how can you call it as an S wave unless and until you cross the baseline like this? On the other hand, if you have only complexes like this, so there's no S wave here. It's only R wave here. There's no RS complexes at all. It's only S wave here. I mean, only R wave here in this particular example. So this cannot be called as an S wave. And this is only a monophasic smooth R wave with a particular kind of a rabbit ear kind of an appearance. I don't know. What is the doubt exactly? If that is a doubt, this must be fine. Clear? If one AVL is positive, you're asking shouldn't be lateral. I don't think so. If it's coming from the lateral, it's going towards the septum. So septum only will be positive. One AVL will be negative only. If it's coming from the septum, it moves towards lateral side. So in that particular example, your one AVL will be positive. It's all about the vector that moves. It's not about where it originates. For that matters, if it originates from the apex, so your V4 should be positive, right? But AVR is positive if it originates from the apex. If it originates from the base, then V4 is positive. So it all depends. Clear not? I told you already. Understood. Fine. So Keshav has understood. Good. That's all. So that is the basic idea. It's actually quite simple only if you think in a very good way, if you read it one more time. But I think if you understood this, I mean, this is a very complicated thing, but still if you understood, we can move on to the next one. That is the diagnosis of tachyarrhythmias. Clear. Of course, it will take time. It will take a lot of time. But still, you need to practice ECGs. No, like it's not like a overnight thing. So for me to explain this or to come to a level of explanation, it took years for me. And I really didn't have any teacher. No, like sometimes I feel envy most of the times because the amount of teaching that you are getting right now is something we are deprived of. We don't really get at all in the first place during our time. We are really deprived, and in a sense, like they will teach us, no problem at all, but you are spoon-fed. There's a lot of difference. So we used to read ourselves and we used to understand ourselves. You are completely spoon-fed. Indra is asking any resource to practice ECG, any website. I really don't know. Many students, as a beginner, they go to that Life in the Fast Lane, LATFL. That's where they go, according to me. Yeah, many students go to that only. That gives a basic idea about what ECG is. To a basic level, you can understand that particular electrocardiogram and related stuff. But if you want to go to an advanced level for an MD student, then that won't be enough. Good book for reading about ECG. You are on UG or a PG? That's the first question. Undergraduate or postgraduate? UG. If you are a UG, then Making Sense of the ECG will be a good book. Making Sense of ECG by Andrew Houghton. That's a decent enough book to start with the undergraduate level ECGs. Yeah, apart from that, that's okay. Okay. So then let us move on. So if you're a postgraduate, then probably you can go towards Goldberger or something. For PG, Goldberger. Goldberger is one thing. Then we have, for arrhythmia specifically, we have Luna. So that's also a good book. Then Goldberger is a good book. And of course, you have Shamroth for ECG. That's also a good book. So, but I never read Shamroth. I usually go towards Goldberger, or most of the times I generally read from Braunwald and other cardiology textbooks. John Ampton's ECG made easy. That's also a good book. But anyways, how much ever books you read, ultimately you are the one who's going to practice. So once you cannot see the ECG and tell in the OPD with confidence, there's no point in reading any textbook. So read until you sit in the OPD, see the ECG, and concretely diagnose that this is the diagnosis. Till that you have to read. That's all. As simple as that. Whatever source you read, whatever textbook you read, it doesn't matter. If you're not having confidence, it's a waste, finally. Okay. Then the next question, next point that you are going to diagnose, discuss is on the diagnosis of the, arrhythmias. So to diagnose an arrhythmia, and before that we are not talked about the fascicular VT because I got distracted with your questions. We have not discussed on the fascicular ventricular tachycardia. So what do you mean by fascicular tachycardia? Fascicular VT is the same as that of ventricular tachycardia only. Is the same as that of VT, fascicular ventricular tachycardia, but you will not have a very wide QRS. Usually one of the important points about a VT is if you want to tell the 12th point, very wide QRS, very, very wide QRS, extremely wide QRS, like more than 160 milliseconds. That is more than 4 small boxes, very, very wide QRS. So that is usually goes towards a ventricular tachycardia. That's one of the signs of a VT. But fascicular VT is known to have a borderline or a narrow QRS. For example, they might have somewhere between 0.10 to 0.12 seconds. So which means they will not have a very wide QRS, but it cannot be called as a narrow QRS also. It will be somewhere in between. That is very a characteristic of a fascicular kind of a VT. Apart from that, it will have all the other evidences of a ventricular tachycardia, but it might not match the RS complex and all. As per the Brugada sign, it should be more than 100 milliseconds, which you have seen here. It should be more than 100 milliseconds. But as far as fascicular tachycardia is concerned, it will be around like 40, 60 milliseconds. It will not be more than that. So apart from the time interval, all the other evidence of VT will be there, like AV dissociation may be there, and that Verrecke sign may be there. All the other evidence of VT may be there, but except for the few signs. But the numbers will be a little less. So usually they will have a little bit of narrow complex kind of an appearance only. Ventricular rate that fast must be treated like a VT regardless of narrow or wide QRS. Yeah, in a sense, it's correct. But ultimately, whether you save the patient or not is what matters in real time. So whenever in doubt, I told you treat like a VT. If you can't really predict with a lot of confidence, it's better to treat with a VT. Ultimately, you take a cardiologist. They will speak so much in the conferences. Like, this is how you differentiate, that is how you differentiate. But ultimately, when it comes to practice, if you call and ask if you send the ECG, ultimately, they will tell give you amiodarone. That's what they're going to tell. That's what is going to happen in reality. They're going to treat it like a ventricular tachycardia only whenever in doubt. So later on, you can assess what is the idea. Then if you really don't know, then go for EPS, electrophysical studies, which is going to tell the diagnosis very concretely. Anyways, now take the diagnosis. How to diagnose the ventricular tachycardia? For that, we need to know first whether it's a wide complex or a narrow complex. First, let us take the tachycardia and see whether it is a wide complex or narrow complex. So I'm going to see the QRS width, whether it is narrow or whether it's a wide complex. So if it's a narrow complex tachycardia, next I know I should see the rhythm analysis. If it's rhythm, if you see if it's regular or if it's irregular. If it's a regular rhythm, look for the P waves. If P waves are regular and if it's coming in 1:1 ratio preceding the QRS complex, then see the morphology. Morphology, you have a normal morphology or a abnormal morphology. If it's a normal morphology, then it must be a sinus tachycardia. If it's an abnormal morphology, then very likely it will be a ectopic atrial tachycardia. So if P waves are not seen or probably is invisible, not seen, you're not able to see the P wave before the QRS, or if it's invisible, then very likely your diagnosis will be either an AVNRT or probably a AVRT with orthodromic conduction. AVRT with orthodromic conduction. If it's an irregular rhythm, once again, I'm going to look for the P waves here. If the P waves are there in an irregular rhythm, there are multiple possibilities are there, but let me tell you certain possibilities. If the P waves are there here, so in this condition, I'm going to diagnose probably a MAT. So in this, definitely there will be at least 3 different P wave morphologies, which you have discussed already, or there are many alternatives like certain ectopic atrial tachycardia that is coming at a very high rate also can produce this kind of an irregular appearance, but that's not a problem. So usually in this setting, you're going to diagnose a MAT only if you are able to see the P waves with 3 different morphologies. The P waves are absent, then my diagnosis will be atrial fibrillation. And please understand, most important thing about sinus tachycardia and atrial tachycardia is the fact that P waves will be located at expected position. So where you expect the P waves to be, that's where the P waves will be. Unless and until there is a block, so I mean AV nodal block, your P waves will be there at the expected position. It will be before the QRS. But whereas in AV-NRT and AV-RT with autonomic conduction, the P waves will not be at expected position. Even if you see a P wave kind of an appearance, it will not be at expected position. Most of the times, P waves will be distorting the QRS complexes. So it will be within the QRS most of the times and it will start distorting the QRS complexes. That is how your AV-NRT or AV-RT with orthotropic conduction will behave like. And atrial fibrillation, you know very well, you will see the fibrillatory waves sometimes that you should not confuse with the P waves usually. That's one of the important things. You want to fit an entity called wandering atrial pacemaker. I don't know really, like where you study all this, man, wandering atrial pacemaker. But there is an entity called VAP. Yes, really true. You have VAP, wandering atrial pacemaker. It's the same MAT only, but if the rate is less than 100, we call it as VAP. If the rate is more than 100, that's a multifocal atrial tachycardia. But if the rate is less than 100, but you have the same kind of 3 different P wave morphologies, then it will be called as a wandering atrial pacemaker. VAP. That's type of arrhythmia only, but that's not really important for us right now. So then you have wide complex tachycardia. If you have wide complex tachycardia, then next step is to see whether it is regular. Rhythm is important next. So whether it is regular or irregular. So you have an irregular rhythm or a regular rhythm. So then next, look for the P waves once again. If P waves are regular or P waves are regular and is coming in 1:1 ratio, then it must be not SVT. You can simply call it as a sinus tachycardia with a probable bundle branch block. Sinus tachycardia with a probable bundle branch block. If the P waves are invisible, you're not able to see the P waves properly. Invisible. Then in this setting, the first diagnosis I'm going to make is ventricular tachycardia, of course. And the second diagnosis we know, it is SVT with aberrancy. As far as SVT with aberrancy is concerned, it could be many possibilities. As I told you, it could be a pre-excitation related AV-RT. It could be a result of pre-excitation, as I told you, AV-RT with orthotropic conduction with bundle branch block, or it could be AV-RT with antidromic conduction. So pre-excitation related SVTs can produce with an aberrancy. If it is there, then you can get this kind of pattern. Or second possibility, as I told you, what is second possibility? Already I mentioned AV-NRT with bundle branch block. That is another SVT with aberrancy. We discussed already. Or simply it could be rate related. So as I told you, in higher rate itself, sometimes your bundle branch may go for block because of at very high rate. Sometimes they can go for irregular blocks. For example, for that is an Ashman phenomenon. So it could be rate related aberrancy also. But anyways, nevertheless, the word SVT with aberrancy is the most important. Clear? So I'm rubbing this off. So we have discussed all these things already. So VT or SVT with aberrancy. To differentiate that only, I've told you already. We know all the stuff which I told you already that differentiates between VT versus a SVT with aberrancy. So no need to once again dig all those things. Suppose if it's an irregular rhythm, then next step will be, remember, irregular rhythms definitely rules out a monomorphic VT. It cannot be a monomorphic VT. Now you have to know whether is it a polymorphic VT or not. So now the differential diagnosis can be anything. It could be a polymorphic VT, or it could be a Tossard's, or it could be probably a condition like atrial fibrillation with bundle branch block, or other rare conditions like MAT with a bundle branch block. So these are some of the rarer conditions that's going to produce an irregular rhythm. But remember, these are very easy to find out, not a big deal at all. So I know, like AF with bundle branch block, how MAT with bundle branch block will look like, because you're going to really have P waves. So that's not a problem. But my problem is this only, polymorphic ventricular tachycardia and Tossard's, because these both are spotters. Very important. So how will you find out whether it's a polymorphic VT or a Tossard's? That's my question. So in that, you have to differentiate between a monomorphic VT versus a polymorphic VT, because it's very easy basically. Why I told you it's spotters is because it is going to be extremely easy how we're going to find out. So if you take a monomorphic VT, if you take a V1, either you will not be able to see anything. It will come like this. Either you will not be able to see anything here, or you will be having a clear-cut RBB kind of a morphology, which means something will be there. So which means the morphology will be the same. It won't change throughout the ECG. So the same morphology in V1 or any other lead will show the same morphology only. That is suggestive of a monomorphic ventricular tachycardia. But on the other hand, if you see polymorphic ventricular tachycardia or a toss-eddy pointers, we know what do you mean by polymorphic VT. We have discussed only monomorphic VT. We have not told what is polymorphic VT. In a polymorphic VT, what's going to happen is you're going to have VT that is originated from different locations. How we told you for multifocal atrial tachycardia, like that one will originate from this area and that will go. And again, the next complex will originate from this zone and that will also go. And next complex will probably originate from this zone. Next complex from here, next complex from here, next complex from here. So as I told you, as a common electrophysiological principle, if different complexes originate from different zones, they'll be having different morphology or same morphology. Same morphology or different morphology. Of course, it's going to have a different morphology. So if it's a different morphology, and it's easy to find out. So it's a VT only, but it's a different morphology. For example, you might see a right bundle branch block pattern in V1. Suppose let us take V1 as a right bundle branch block. Suddenly what it will do is it will change into a left bundle branch block pattern. So you can see an abrupt change in the morphology from RBB to LBB pattern, which means definitely this is a polymorphic VT. Or you can see beat to beat variability also. If it's a very severe case, highly irritable myocardium, then you might see one complex will be coming like this with an RBB pattern. Another complex you can have an LBB pattern, and next complex LBB pattern, and again other complex with RBB pattern, then another complex with different kind of a morphology you really don't know, maybe something like this, then another morphology coming like an LB pattern. So you can see different morphology. So that's why the name itself tells it's a polymorphic ventricular tachycardia. You have different morphology. This will not be seen in the monomorphic ventricular tachycardia. And what about toss-sats? Is there any way to tell that the patient is having a toss-sats? Toss-sats, if it happens in a long QT, the same PMVT we called as toss-sats. But toss-sats will have some ECG kind of a difference. For example, the name toss-sats in German means it is twisting of points, which means that there is a twisting of the QRS axis. For example, you will have a VT that is happening like this. Suddenly, slowly, they will become and change into a morphology like this. And again, over some time, you cannot find out. Then again, you will see this kind of pattern. So which means what's really happening here is slowly, like initially it was positive, let us assume. Slowly it has become negative. And over time, slowly it has become positive. So which means slowly it is twisting from one axis to another point. So that kind of slow twist from one axis to another axis or one morphology to another morphology is what we refer to as something called a toss-eddy point. Typically, it's Germany for twisting of points. The slow change in the axis from one certain group of complex will have one axis. Slowly, they will change to another. There won't be any abrupt change in the axis. That is what we refer to as a toss-eddy pointer. But nevertheless, toss-eddy pointer is also a type of a polymorphic VT only, but happens in the setting of a long QT syndrome. That's all. That much if you know, that's more than enough. And A with bundle branch block or not, it's very easy to find out. So that cannot be confused with your polymorph VT at any cost. AF with axillary pathway is also DD for wide complex tachycardia. Yes, of course, it will be irregular. AF with axillary pathway. Good. Actually, I'm very happy with Alex. Alex told that this could be a differential diagnosis for wide complex tachycardia, and of course, it will be irregular. Perfectly correct. So instead of writing here, I can probably write in a single sentence. I can remove this bundle branch block word. I just told, for example, I can write AF with aberrancy. Or I can modify my statement as MAT with aberrancy, because aberrancy includes the pre-excitation pathway. Is it okay, Alex? Now I think it will be perfect, right? AF with aberrancy or MAT with aberrancy. Yes, he's happy now. Okay. Thank you anyway, because Alex told only I changed this. Thank you, Alex, for your suggestion. But anyways, so this is going to be the final summary for you. So this is going to be the diagnostic algorithm where you're going to diagnose different arrhythmias. So let us move on and discuss some of the ECGs now. Let us see what kind of ECGs we can discuss. Found out we have diagnosed this. This is a trifascicular block we have diagnosed. This is an electrical alternance. And I mean, this also shows some kind of tachycardia. It's an electrical alternance, but what kind of tachyarrhythmia you are seeing here? Let us start with this because I thought this diagnosis was not there in my presentation. Let us start with this. You have a tachycardia, of course. There's no doubt about that. To start with, you have only 1-2 complexes. I mean, 1-2 large box between these two complexes. So definitely rate must be somewhere, not 150 really, because you have some gap between that. So rate must be somewhere around 120, 130 here. That's the rate here. But definitely less than 3 large boxes. Everyone should agree that only 2.5 large boxes are there between these complexes. So what is the diagnosis here? So very simple. So now it's a narrow complex, of course. So there's no doubt about that. This is definitely a narrow complex. If it's a narrow complex, next step is what? What is the next step? See the rhythm. Rhythm is regular. You can see it's very, very regular. I mean, as a whole, if you put the scale, it is very regular. So it must be a regular rhythm. So narrow complex, regular rhythm. What is the next step? Look for the P waves. So P waves are there or P waves are not there first? P waves are definitely there. And is it regularly coming before every QRS? Yes or no? Yes, it's regularly coming before every QRS. All right. So P waves are there and it's regularly coming. So what is the next step? See the morphology. See in lead 2 and lead AVL, where it should be definitely positive. In many, I mean, all the limb leads, usually P wave is positive except for the AVR. But 1 and AVL, if you see in exam, it's more than enough. It should be usually positive. In 1 AVL and lead 2 in all these leads, if it's positive, then it's fine. So it's positive or negative in limb leads? P wave. Positive or negative? Of course, it is positive, which means it's a normal morphology. So P wave is regular and it is normal as well. If P wave is regular and if it is normal, then your diagnosis must be sinus tachycardia. As I told you yesterday, this is an ECG of an electrical alternance where you'll see a triad of finding sinus tachycardia. Then you have that kind of low voltage QRS complexes and you have electrical alternance. Electrical alternance. This is typical of a tamponade here in this particular example. Then, yes, what is this diagnosis? I mean, don't tell the diagnosis straight away. Tell me the rate first. I mean, you need not tell the rate. I just want to know whether it's a tachycardia or not in the first place. So definitely the tachy, like it's less than 3 large boxes. So surely it's a tachycardia. So first, it's a tachycardia. Next, what about the rhythm? Rhythm is regular or irregular? What is a complex? Narrow complex or wide complex? Of course, it's a narrow complex. It cannot be a wide complex because if you see in V1, it's definitely narrow. And if you see in many other leads, it's surely narrow. So, okay, narrow complex, regular or irregular rhythm? Okay, tachycardia, narrow complex, regular rhythm. So if it's a regular rhythm, what is the next step? Look for the P waves. Are you able to see any P waves before the QRS complex? P wave abnormal. Where is the P wave? Show me a P wave. So if you think this is the P wave, where is the T wave then? Show me the T wave then. And students who are thinking this is the P wave, where is the T wave? Then you have to show the T wave for me. So is this rhythm having P waves at usual location? At the usual location you see before the QRS. Is there any P wave? Am I able to see any P wave here? I don't think I can see any P wave. So invisible P waves. Invisible P. So what is the diagnosis? What is the diagnosis? AVNRT, right? AVNRT with orthodromic. I mean, AVNRT with orthodromic conduction. I mean, it could be AVRT with orthodromic conduction, but I want a simple diagnosis. It's likely to be AVNRT, right? But your diagnosis is wrong. Whatever we did is wrong. Whatever we did till now is absolutely wrong. The diagnosis here is atrial fibrillation. It's an AF. It's actually an irregular rhythm. That's why I left it to you. That's why you should not really come to a conclusion that straight away, like it's a regular rhythm and all these things just by looking at it. So you should really measure it. Even in exams, just look at the 10 beats carefully. Yes, just look at 10 beats. Just 10 beats. That's what I want. So take from here, randomly I'm choosing. I'm closing my eyes. I'm choosing from here, probably to here. Look at, I close my eyes and chose. So just see the 10 beats, nothing else. So see the distance here, just outright, and see scan and see the distance here. And come, see the distance here. You think now it is regular or irregular? Irregular or regular? Of course it is irregular. So never be in a haste in exam, because it's such a common rhythm, atrial fibrillation. And if you really miss this, then you will feel really worrying about that. This is a very simple and easy thing. So that's why I went about, because many people have told you regular. So I got surprised. Then I started realizing that let us go in your way. Okay. So this is an atrial fibrillation rhythm because it's tachy, irregular, and narrow QRS doesn't matter, but you have no P wave. So all these things tell you it's irregular rhythm. But in AVF, you are seeing some this baseline undulations. This kind of undulations in AVF means this patient is probably having a fibrillatory waves. These are not really P waves. These are fibrillatory waves. In lead 2, I am not able to see any P waves for that matters. It's a straightforward atrial fibrillation. And what is this? This we are not put in the algorithm at all. Then how will you be knowing that this is the rhythm? So this is an atrial flutter. That's what I want to tell, because in the tachycardia algorithm, we don't really have this idea. Remember the fact that there are certain spotters are there in tachycardia algorithm. So what are the spotters? You have the atrial flutter, then you have the ventricular fibrillation, we have the PMVT and tossets. So these are some things which are basically spotters. You don't really need to bury and dig into the algorithm. So it's just spotters. Just by look at it, you can find out. For example, the only way to find out flutter as far as exams are concerned is see lead 2. And trust my word, see only lead 2, don't see anything else. If you see anything else, you will be confused. Sometimes fibrillation also may show like flutter-like waves in V1, V2 and all. So don't see any of the leads, see only lead 2 if you trust me. And if you see something like this kind of sawtooth baseline, this will not be seen in any other conditions. If you see a sawtooth baseline like this, or these are called as flutter waves or sawtooth waves, so then it's a atrial flutter. So come back to the ECG and see. You won't be able to see this kind of pattern anywhere. So these are the flutter waves we are dealing with. These are regular flutter waves basically. These are the flutter waves. I mean, if you want to draw properly. So you can see that these flutter waves are coming very regularly. So this is what we refer to as sawtooth baseline. And don't see anything else. Just see this undulation, this area you see. And if somebody tells this is a flat baseline, and I don't know what is then sawtooth baseline is. So if you want to really zoom in, I can really zoom in also and show. So I don't think like you cannot see. I mean, you cannot disagree with the fact that this is a sawtooth baseline. So if you want to compare with the AFib, you compare with the AFib. Where is the sawtooth baseline here? Just show me where is the sawtooth baseline. I don't think so. Compare with any other rhythm for that matters. Show me where is the sawtooth baseline here. I don't think you're going to see sawtooth baseline apart from this rhythm. So please take a snapshot in your mind. This is sawtooth baseline and this is flutter, and this is how it's going to look like. So the idea of flutter is to find out this sawtooth baseline. That is that these are inverted P waves basically, correct? Heart rate is 75 in flutter. Heart rate is highly variable. This is a flutter with a variable block. For example, this area you are seeing only around 2 small boxes, I mean large boxes. So here the rate is around 150. But if you take here, it is 1, 2, 3, and 4 almost. So here the rate is 75. And here I think it's showing a pattern. Even I was not aware of that. I think I have to thank Riju only for telling this. This patient is having an, interesting thing. He's having an alternating 2:1 to 4:1 block. So he's having alternating 2:1 to 4:1 block. That's what the patient is having. Here the patient is having not 2:1, I think, yeah, 2:1 block. So he's having 2:1 QRS and 1:2:3:4 and 1 QRS, 2 P wave 1 QRS, 1:2:3:4 P wave 1 QRS, 2 P wave 1 QRS, and 1:2:3:4 P wave 1 QRS. So I think he's having an alternating 2:1 and 4:1 blocks. One beat is having 2:1 block, other beat is having a 4:1 block. So that's why I told you this can be simply explained as a flutter with a variable block. I told you already. In flutter, there is no point in seeing the regularity of the rhythm and all, because if you take in a broad sense here, the rhythm can look absolutely irregular. So you cannot really tell that. The idea of doing a flutter is identifying this sawtooth baseline. Without that, it's very, very impossible to find out that this patient is having a flutter. So don't think about anything else. So that's a sawtooth baseline, that's a flutter. And what is this ECG? What this is showing? What this is showing? Tachycardia, yes, Alex. So definitely 1, 2. Definitely it's rate around 150 tachycardia. So if it's a tachycardia, what is the next step? Please don't tell the diagnosis, man. Whether it's, next step is to find out the QRS complex. Narrow QRS or wide QRS. So of course, anywhere if I see this must be definitely a narrow QRS tachycardia. If it's a narrow QRS tachycardia, then what is the next step? Regularity, regular or irregular. So everywhere if I see this is 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. I think it's mildly regular. I'm seeing the same kind of distance between all the QRS complex. So it must be regular QRS. If it's a regular QRS, next step. Am I able to see any P wave at the usual location? So usual location is here at this point. Am I able to see any P waves at this point at the usual location? It's invisible. I'm not able to see P waves at usual location. So it is basically not a atrial tachycardia. So it means this must be very likely to be a AVNRT. Remember, it's very difficult to differentiate from AVRT with orthotomic conduction, but still in exams, my diagnosis usually will be a AVNRT. So what are the points that favor AVNRT here? Because I have two crucial points that favor AVNRT here. That's the typical pseudo S pattern. So if you see very carefully, that this QRS in lead 2 is showing this kind of a undulation at the base. So if you want to zoom and see, you can see. I can't write once I zoom. So you can see at the end of the QRS, you can see that kind of a notching. So I think it's very clear now. I cannot zoom more. There's a maximum capacity for zoom because you can see on the iPad itself, it's showing maximum. Clear? So what is it showing? What is this? What I'm trying to tell? What is that? What do you mean by that? Why I've zoomed you this much and I'm showing? Yes, it's a pseudo S pattern. So that's what I want to show, because you have a pseudo S here. And go to V1, scroll to V1. What are you really seeing there in V1? Can you see in V1? This is a V1. So what are you seeing in V1? Yes, that's a pseudo R dash. Correct. So I'm actually scrolling to show the pseudo R dash pattern in V1. So this is definitely AVNRT only, for sure, because that too usually is unlikely to be AVRT with orthotomic conduction. There it will not be seen mostly. So it is very likely to be a AVNRT only. That 2 points which I've told you. So then what is this basically? What is this? First of all, it's a tachycardia or not a tachycardia? Tachy or not a tachy? Definitely a tachycardia. So you have around 1, 2, and around 2.5. So I can tell around rate around 120 here. Definitely it's a tachycardia. So it's a narrow complex or wide complex. See the complexes. You think these are narrow complexes or wide complexes? Oh, yo, Keshav, wide complex. Ayanda, why? I mean, sometimes you might have this intraventricular conduction delay, man. But I don't think this is a wide complex. It's a Pakka narrow complex only. And if you want, you can zoom and see also. I'll show you later on. I mean, you should have some conscience, man. See this waveform and see and tell. You are not even having one small box and you are telling wide complex. Wide complex or narrow complex? It is definitely narrow complex. See here, man. See how many small boxes are there. Not even two. I mean, we should have some conscience, no? To tell this as a wide complex. This is definitely narrow complex. So tachycardia, narrow complex. Then after narrow complex, what else? Regular or irregular? So let me see some 10 beats. At least 5 beats here. So regular or irregular? Regular or irregular? Why people are telling it's irregular? Okay, let us see the scale. So regular or irregular here? You see some 10 beats and say, yeah, of course, it's around 2.5 boxes. All the things are having 2.5 boxes. So here 2.5, then here 2.5, then here 2.5, here 2.5, here 2.5. I think, do you think it's regular or irregular? Now at least. So now you are convinced, okay, it's a regular rhythm. Okay, regular narrow complex. So P waves, I mean writing in a different ECG, I think. Okay, regular narrow complex. So if it's regular and narrow complex, is the P waves present in lead 2? Are the P waves there? See lead 2. Are the P waves there? Okay, I think you're not able to see. What are these then? What are these then? What are these? Are you seeing P waves before the QRS? Are you seeing the P waves before the QRS? Yes or no? Are they having usual morphology or a different morphology? Different morphology. So what is the diagnosis here, basically? What is the diagnosis here? It's an ectopic atrial tachycardia. Yes, correct. What is this one? Okay, fine. It's very common ECG in exam once again. So what is this one? First of all, it's a tachycardia or not a tachycardia? Tachy or not a tachy? Okay, tachycardia. Next step. Narrow complex or wide complex? Anyway, in this ECG, it won't matter, but it's a narrow complex. If it's a narrow complex, it's regular or irregular? Definitely irregular. I can see, surely it's irregular. And at this point, like it's only this much. At this point, it's this much. So there's no doubt about that. It's irregular. So if it's irregular, next step, look for the P waves. P waves are there or not there? P waves are there in an irregular rhythm. If P waves are seen very clearly, then very likely it should be a mat. But to prove it's a mat, I mean, if it's same morphology, then you have to think about something else. There are a lot of other different answers are there, but usually it will be a mat. So prove that there are 3 different morphologies. So first, one morphology, this is a different morphology. Here you have an inverted P wave, different morphology. And this morphology is different. It's looking like some M. So this is different, this is different, this is different, this is different. And of course, this is also different. So I'm seeing almost 5 different morphologies here of the P waves. So definitely the diagnosis here is multifocal atrial tachycardia. Clear? Okay, all right. What is this one? First of all, straightforward. See and tell, touch your consonants and tell this is a wide complex tachycardia or narrow complex tachycardia. Wide or narrow? Nobody can deny this fact. This is definitely a wide complex tachycardia. So now you have to look for the signs of ventricular tachycardia. So is there any sign for ventricular tachycardia? That's what you're going to look. So in exam, whenever you get something like this, it's a VT only. That's all. There's no doubt about that. If you see this kind of wide complex, most of the times they'll be asking about VT. Monica is telling it's a polymorphic ventricular tachycardia. Where is the evidence of polymorphic VT? See the V1. V1 you are seeing a positive complex or negative complex. Throughout V1 you see, and touch your heart and tell it's a positive complex or negative complex. Positive or negative complex? Okay, in V1 you are seeing a positive complex. Everywhere you are seeing a positive complex. Is there any morphology change in V1? Then how can you tell it's a polymorphic VT? I don't think it's a morphology. Is there any change? I mean, and again, Abhiram is asking, is it tossed? Where is the change in the morphology in V1? So you are entering V4. V4 is showing some morphology, all right? V1 is showing the same morphology, right? Where is the change in the morphology here? So there is no concordance here. See, how can you tell a concordance? Remember, you are able to tell this is R wave, this is S wave. No, you are able to tell this is R, this is S. Where there is concordance here? There is no concordance. Concordance means it should be something like this. This is concordant. That's not a concordance. Here you are able to tell this is R, this is S. If you are able to tell which is R and which is S in a particular precordial lead, that is not concordance. So there is no concordance here, of course. Amia is telling sinus tachycardia with bundle branch block. No. See, first, see one important thing here. This patient is having very high rate. Like, let us assume, what will be the rate here approximately? Approximately, what is the rate here? Approximately, it's not 300, but around 270, I feel, because it's not strictly one large box, but maybe around 7 small boxes. So around 7 small boxes is the key here. If you calculate everything, it will be 7 small boxes. So you don't see any P wave. So it can't be sinus. And logically speaking, can sinus node produce this much rate, 270? If you really want to tell it's a sinus tachycardia, can a sinus impulse, can a sinus node produce 260, 270 or 280 rate? It's impossible. You cannot do that. So it's not sinus. So that's why at such a high rate, don't diagnose things like a sinus tachycardia. So it's a VT only. How I'll tell it's a VT? The clue is C, AVR, man. You have Wernicke sign positivity here. That is basically AVR. That's a Wernicke positivity. And definitely this is a straightforward sign. You will have at least one sign in exam to tell like that. So that's Wernicke's AVR positivity. And that is definitely, ventricular tachycardia only. If you really want to zoom and see, you see what you're seeing here. It's a full positivity in AVR. Clear? I can't explain anything more than that. So it's a VT only. And not seeing QS. Okay, fine. So once you decide it's a VT, can you localize a VT where it is coming from? Suppose if you know it's a VT, localize where it is coming from. Yeah, AV dissociation is also there. If you really want to know where is the AV dissociation, you have to see all the beats. Then only you can find out AV dissociation. If you want to know one area where I can show AV dissociation cleverly, I can show in the second beat. First, let me mark, then you can see. So if you see, this is a QRS. This is a QRS. And in this QRS, you can see this pattern. So what is this one? That's actually AV dissociation. For example, if I zoom, you can see, you can focus on the second beat. You can focus on the second beat from V1. I'm going to zoom now. You just focus on that. Can you see a P wave that is superimposed? Rabbit ear sign is not positive here. Rabbit ear sign is negative because the left rabbit ear is still smaller than the right. Left rabbit ear is smaller than the right. So this is not a sign of a VT. So here rabbit ear sign is not seen. But can you see a P wave? I mean, in the sense like in V1, the second beat. Can you see the P wave before the QRS? That is coming like a bump. Can everyone see that? So that is a sign of AV dissociation, surely. Compare with all the other QRS complex, and that only one QRS is actually having a P wave. I'll come back to that. What is a fusion wave and what is a capture beat? So that is definitely a ventricular tachycardia only, surely. So this is a VT. Suppose you have a lot of evidence to tell it's a VT. Suppose if it's a VT, which ventricle it's originating from first, can you tell? LV or RV? Okay, it's coming from left ventricle. Which location? First tail anterior or posterior? Keshav, anterior. How it's anterior, man? Tell me. See 2-3 AVF. 2-3 AVF is negative. If 2-3 AVF is negative, it suggests you of an anterior fascicular block pattern, which means it's a posterior conduction. So it's posterior anterior. It's a posterior. So it's a posterior VT, LV posterior surface. Then what else? It's coming from apex or base. See AVR. AVR is positive and V4 is negative. AVR is positive. So it's traveling towards base, that is towards AVR. So it has to start from the apex. So it's starting from apex and going towards the base. So it's an apex. Then it's coming from LV apex posterior surface, septal or lateral. So C1 and AVL. So one is most important here. One is negative or one is positive. One is negative. AVL may be different, but one is negative. So one negative means what? It must be lateral. So it's coming from left ventricle posterior apical part in the lateral side. So the diagnosis is confirmed. So this is LV posterior wall, apical, and in the lateral segment it is coming from. So that's how you localize a ventricular tachycardia through ECG. Fine. So you know it's a VT only. Cool. Then I mean, do anyone see this one as positive? Because Keshav Riju is telling this one looks positive. I don't know where one looks positive. It's negative only, no? It's not positive. Okay, go to the next one. So what is this one? This is definitely a VT. Straightforward, you have a sign. So surely I'm telling you it's a VT. Why it's a VT? Because you have a taller left rabbit ear compared to the right rabbit ear. So localize the VT. It's originating from the left ventricle and it's originating from the outflow tract, anterior part. And at the same time, it's originating from the base. We told you already. And it's coming from the one AVL is negative. So it's coming from the lateral side. That's all. So LV outflow base lateral. So this is the typical localization according to this ECG. In which lead to look for rabbit ear? Only V1. V1 is the only lead where you have to look for rabbit ear. I mean, V1 is the place where you're seeing whether it's an RBB pattern or an LBB pattern. So that is the place where you have to look for the, like rabbit ear pattern. If you have any confusion. So this is definitely a LV outflow tract basal and it's coming from the lateral area. Fine. What is this one? This is, once again, I feel it is supposed to be a VT only, but this is a special form of a VT if you tell. It's a VT only, surely. So how will you tell it's a VT? Because it's a very wide complex. So I told you whenever the complex is more than 160 milliseconds, that is a strong sign of a ventricular tachycardia. So if you see in certain complexes, if you take the width, I think the width of the QRS at the base is actually more than 5-6 small boxes. I don't think it will be less than 5-6 small boxes. Suppose if you really want to see here, so definitely this width will be more than 5 to 6 small boxes. Concordance, you cannot call it as a concordance because I'm able to see an RS pattern here. In V2, I'm able to see an RS pattern here. So if you're able to see an RS pattern, I don't really think about like ventricular tachycardia here. So this is not a VT. I mean, this is not a concordance. I mean, that goes towards VT, concordance, but here you don't have a concordance. Yeah, it should be seen in all precordial leads. Every single precordial leads, you should be able to see concordance, then only. AVR is negative, but AVR is not like surely it should be negative. I mean, it should be positive. It's one of the signs of a VT. You will not be seeing all the signs of VT in the same patient. Any one, if you see, that's a VT. It's not like everything it should satisfy. So we are not telling criteria. We are only giving if this is there, it's a VT. So AVR can be negative. I told you it can produce any axis. Why it can't produce a left axis and produce a AVR negativity? So you cannot tell with AVR negativity it's not a VT. That's a very stupidity to rule out VT like that. No. So it's definitely VT only, man. So why it's a VT? Because your complex size itself is very big. Such a wide complex tachycardia you will not be getting in SVT with aberrancy. It's more than 160 milliseconds. And of course, it's, I mean, if you see Brugada sign, it will be positive, of course. And certain areas, one area I saw one thing. There is a notching in the QRS complex. The nadir of the QRS complex, there was a definite notching was there. Where is that? I missed that. There is a notching in the nadir. Okay, fine. That's okay. So this is likely to be a ventricular tachycardia only. But if it's a VT, where it's originating from? Where it's originating from, if this is a VT? Okay. So this is an LBBB pattern, left bundle branch block, which means it's originating from the right ventricle. Then if it's from the right ventricle, then it's originating from anterior or posterior. 2-3 AVF is positive. If 2-3 AVF is positive, then it should be anterior posterior. Yes, anterior. It's coming anteriorly. If anterior, probably you can tell it as outflow also. Probably outflow. Then if it's in the apex or the base. AVR is basically negative and V4 is typically positive. So it is typically originating from base. So it's moving from base towards apex. Then final thing. So if it's originating from septal or lateral, see the one on AVL, one negative, AVL is also negative. So it's originating from septum or lateral side. So lateral. This is a localization of VT according to this particular ECG. So RV, anterior, base, lateral. So this is the 3D localization. Okay. What is this one? What is this one? So first of all, it's a tachycardia. What is the tachycardia here? So yes, I mean, you think it's really that wide complex tachycardia? I don't think it's a wide complex tachycardia to start with. So because if you zoom and see, I feel the QRS complex in V1, if you take a V1, I feel it's only like 2 small boxes, isn't it? You think it's a wide or narrow? Wide or narrow? How many small boxes you are seeing in lead V1? Yeah, it's a narrow complex. Okay, but narrow complex, but it's having RBB morphology. Okay, it's a narrow complex tachycardia, but it's having an RBB kind of a morphology. It's RB kind of a morphology, then what else you want to know? What kind of tachycardia is this? Is it an SVT with aberrancy or it's a ventricular tachycardia? So look for the signs. So now if it's a narrow, then you cannot see for that RS and all this ratio and all you cannot see. Go for AV dissociation. Are you seeing any AV dissociation here? Are you seeing any AV dissociation here? Actually, answer is yes. In lead 2, let me show you the AV dissociation. So you can see there's no P wave and you have a QRS complex. Suddenly there is one bump is there. You see no QRS complex. I mean no P wave, no P wave, no P wave still, QRS complex. Suddenly you see a bump here. So no P wave, nothing much, no P wave. Suddenly you are seeing one bump. So now you tell, are you seeing P waves? Yes or no? Yes. So do you have AV dissociation or don't have AV dissociation? Yes, you do have AV dissociation. So what is the rhythm? It must be an SVT with aberrancy or it's a VT. It is a ventricular tachycardia. Clear? So of course it will be a ventricular tachycardia because once you see AV dissociation means itself that's a hallmark and one of the gold standard points for ventricular tachycardia. So it's a ventricular tachycardia. But then why it is narrow complex if it's a VT? If it's a VT, then why it is having narrow complex? Because it is fascicular. It's having a fascicular nature. So that's why it's originating from the fascicle. That's why it's a VT. So can you tell which fascicle it's originating from? Which fascicle it's originating from? For that you have to see the 2,3 AVF. See 2,3 AVF. 2,3 AVF is negative or 2,3 AVF is positive? 2,3 AVF is negative or 2,3 AVF is positive? 2,3 AVF is negative. It is showing LFB pattern or LPFB pattern. It's LFB pattern or LPFB pattern? It's an LAFB pattern. So which means it's a left anterior fascicular block-like pattern. So the conduction should be posterior. And this is a left posterior fascicular tachycardia, ventricular tachycardia. Clear? Do you understand? Are you understanding or not? Yes. So this is a left posterior fascicular ventricular tachycardia, left posterior fascicle VT. All right. Then what is this one? I mean, in that you have one more finding also, which I have not told you. There is something called a capture beat here. I mean, this is a capture beat here. That's a sinus capture. So this I have not told to you. This is one of the hallmarks of VT. I should have told there itself. So now there is no harm. I can write it as a point number 13. So 13 I can tell fusion beat or a capture beat. I mean, this is a very important exam question also. I should have told this. I don't know, for some weird reason I forgot it. So fusion beat or a capture beat. So, I mean, how to find out a fusion or a capture? It's very simple. In the background of a VT, look for the odd man out. Entire VT will be having very chaotic rhythm, but one odd man will be having a normal shaped QRS or an aberrant QRS complex. Only one. I'm not talking about many. If you have different morphologies, then it will become a polymorphic VT. So only one in between, having a little bit of normal morphology or kind of a fusion between a normal and abnormal morphology. 1 or 2 in between is fine. So that is going to be a fusion or a capture beat. So that is quite possible because sometimes if you take a ventricular tachycardia, I told you the SA node is active in most of the ventricular tachycardias. So there is one point where this SA nodal impulse that is reaching the AV node can just transmit it normally down the ventricles. So that is what we refer to as sinus capture, or otherwise called as a capture beat. Or very rarely, there could be a place where this SA node will give an impulse that will be captured by the AV node and will be transmitting down into the ventricles. And at the same time, this VT also will give an impulse. Both will merge together and they'll produce a fusion dance kind of a thing. That is what we refer to as a fusion beat. So what really tells you, I mean, what the fusion beat or capture beat tells is the fact that SA node is active in a ventricular tachycardia, which means you are proving AV dissociation again. See, I mean, one of the important features of the supraventricular tachycardia is the fact, that's why I'm telling from the beginning that the SA node is suppressed in a supraventricular tachycardia. We have been discussing from the beginning. So if you have active SA node evidence in the form of fusion or a capture beat, then it must be AV dissociation, and that again proves that the arrhythmia that you're dealing is with the ventricular tachycardia. So that's the idea here. So where I've been discussing the fusion or a capture beat. So in a fusion beat, you will have something like this. For example, you're having a VT that is running like this. Suddenly you will have a normal sinus beat like this. So once again, you will start getting a VT. So this is a typical example of a fusion beat. So in this, you are seeing the same, capture beat. So in this, you are seeing the same. You can see this 1, 2, 3, 4 here in lead 2. 1, 2, 3, 4, 5. Yes, there's 6. Sixth beat is like a capture. It's a sinus capture. Since you're having a capture beat and evidence of the sprinkled P waves all over the complexes, you're having AV dissociation evidence. So this is definitely a ventricular tachycardia for sure, without a doubt. So this is another example of a VT. Then what is this? What is this one? Yes, of course, this is a VT only. You have found out because the rabbit ear sign itself is telling you it's a taller left rabbit ear. So which means it's showing RBB pattern or LBB pattern. RBB or LBB? It's RBB morphology, which means it should be from the left side, of course. But see the QRS. QRS is narrow or QRS is wide? You're having a narrow QRS or you're having a wide QRS in this particular example? Narrow or wide? You really think it's narrow? I mean, you really think it's wide? It's definitely narrow QRS only. See some places, like see this one, see this area and all. You really think, touch your heart and tell, is it looking like a narrow wide complex? Sorry. Does it look like a wide complex? See this area, see this area and see this one and see. Do you really think it's a wide complex? I don't think it's a wide complex. It's more of a narrow complex kind of a zone. And you're having an RBB pattern. And surely you're also thinking it's a VT. And I have a lot of evidence to tell that there is AV dissociation also. How can I tell AV dissociation here? So look at the T wave here. So if I see that, if I take that, this T wave is normal. 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 What the hell is that? What is that? What is that? That's a sign of an AV dissociation. That's a P wave. Okay, I'm looking at it. All right. So there should be some evidence for this as well, isn't it? So, okay, this and all is fine. Suddenly, what is this? So I'm looking something different suddenly. So definitely this patient, this is a very important sign of an AV dissociation. Apart from the rabbit ear, I'm having evidence of AV dissociation also. So what is this? This is definitely a ventricular tachycardia. But why it is having narrow complex? Because it's very likely to be a fascicular VT. So if it's going to be a fascicular VT, then which fascicle it's originating from? See the 2-3 AVF. That's going to give you the clue. See the 2-3 AVF. It's positive. So which means it's showing a posterior fascicular block type of a pattern, which means the conduction should be in the anterior side. So this is an anterior fascicular VT. That's all. Simple. Then what is this one? I think we are coming to the end. So what is this one? First of all, touch your heart and tell, is this a narrow complex tachycardia or a wide complex tachycardia? I mean narrow or broad complex. This is definitely a wide complex tachycardia, no doubt about that. And this is a spotter. Why it's a spotter? Because it's a polymorphic VT. So very simply, how can I find out it's a polymorphic VT? I'm seeing the complex. I mean, take one lead. Don't see in different leads. So take one V2 only and see here. You are seeing this kind of complexes. Suddenly you are seeing this kind of complex. So what is this an evidence of? I mean, this is not basically a toss set. I'll be calling this as a simply PMVT. That is a polymorphity. Unless and until I have a long QT evidence or I have a typical indication of sign of a toss sets, I'll be calling it as a polymorphic VT only. Clear? So fine. So this is a typical polymorphity. And one more thing, what you can see is this is a different kind of morphology. And this is having a different morphology. This is having a different morphology. This is also having a different morphology. You have multiple different morphologies. So, and change in axis is there. Definitely this is going to be a polymorphic ventricular tachycardia without a doubt. And what is this one? I mean, this is a spotter again. This is a typical ECG of a toss sets. This is a TDP. Why it's a TDP? Because there's a relatively slower change. It will be a long QT only basically, but a relatively slower change is there. For example, if I see this is positive and suddenly it is changing slowly and suddenly it has become predominantly negative. So which means from positive to negative. This is what we refer to as a twisting of axis from positive towards negative. It's better always to look at on V1 or V2. Nothing more you need to see. V1 will give you the most important clue here. So this is a typical sign of a twisting of axis called as TOSAT. So very likely it will be a long QT, and if the patient is stable, the treatment of choice will be magnesium sulfate in this setting. And this we have discussed already. This is a Wolff-Parkinson-White syndrome with atrial fibrillation. This is a pre-exerted AF. Morning we have discussed again. So what is this rhythm? If you misdiagnose this rhythm, then it's a shame for all of us. Sorry, this one. What is this rhythm? And if you see this area, you will not tell your diagnosis. What you're supposed to tell. That area you can see itself and you can tell what is the diagnosis. First of all, see, analyze and understand, is there any formed QRS complexes? Any formed QRS? Show me a good QRS complex here. One good formed QRS complex. No. This is a VFib. This is how it looks like. It looks like as if somebody has scribbled in the paper. That's how it looks like. It's a typical VFib. I don't know. People are telling AFib and all. I don't know. It's a huge sin to tell this as an AFib. And this patient will be coming in the stretcher in coma stage, and he will be having no pulse. Ventricular flutter. You want to know how ventricular flutter will look like? I think I have skipped this ECG, isn't it? This and this we have skipped, I think. This we discussed this one. This is how ventricular flutter looks like. So ventricular flutter, I told you the rate will be more than 250, all right. But you will be seeing only sine wave everywhere. You will be seeing only sine wave, nothing else. Okay. One important clue I will tell you. This is very easy to find. Let me edit and show, then you will understand. I want to turn this one. Okay, I couldn't do anything. So just if you're having a mobile or if you're having a tab, I can't do that. So just turn ulta and see. Turn the mobile or turn the tab upside down and see. Tell me, are you seeing any difference from what you're seeing in the top to bottom direction? Look at ulta and see whether you are able to tell anything, any difference. Are you able to tell any difference from what you are seeing? That's flutter. That's all. That's how flutter looks like. Symmetry. Flutter. Okay. Cool. So this is an AFib. I'm sorry. This is a VFib. Sorry, this is a ventricular fibrillation. Clear? So this is a typical example of a VFib. And you should not misdiagnose this. This patient will be a... I mean, if she wants, Harita wants AFib BCG. Where is that AFib BCG? Yeah. In what way this ECG and this ECG are similar? Yes, Riju is telling I have committed a sin. Okay. But I'm not Johnny Sins. Okay, cool. So this is basically a ventricular fibrillation. That's all. This is how it looks like. I don't know really how can you mistake this to be atrial fibrillation or ventricular flutter. So this is a spotter, and if you see at certain locations, for example, if you see this area, if you see probably this area, and if you see maybe in some other area like this and all, there is no formed QRS complex at all. If you don't see any formed QRS complexes like this, you cannot discern anything there. What is this area? I don't think so. This is not any other algorithm for sure. I mean, turning upside down clue is for, this is, yeah, she's asking whether it's for a VFib or a ventricular flutter. So first of all, I'm telling this should not be confused with flutter in the first place. Flutter is completely different. See how it looks like. It's not a flutter. If it's a ventricular origin, usually the complex will be big. Number one point. It will not be this small. And you are typically seeing a formed QRS complex here. This is a fully formed big QRS complex that is formed here. You can see definitely this is a good, nicely formed QRS complex. And if you want to take a fib, I don't really see what is this, I can't really see what is a problem in mistaking this as a, flutter or probably as a ventricular tachycardia. And more importantly, students give different answers in different areas. They give this as a AF, as you all told. Somebody is confusing with a flutter, which is absolutely not correct. And then some students will give this is a diagnosis of polymorphic VT. Some students will tell it's a torsady pointer. Because why they'll give polymorphicity or torsady, they will think like this is a complex and suddenly it is changing to a different kind of a thing. So, first of all, see whether formed QRS complex is there in the form. I don't think there is any formed QRS complex here. There are a lot of areas you don't see. So this is like just you are scribbling something randomly in the ECG. That's how it looks like. So definitely it's a ventricular fibrillation. So this is the big clue, and never ever misdiagnose this ECG to have a PMVT or a ventricular tachycardia. In exam, if they give this ECG, which means the patient will be surely in coma and patient will be in shock and he will not be able to see any pulse and the patient will be in Pakka cardiac arrest. So definitely this is a very, very important ECG that you should know. The patient will be in cardiac arrest for sure. So don't misdiagnose this kind of ECGs. Okay, remaining all these things I have completed. So with this, we are finishing the arrhythmia things, and I'm not going to show any of the ECGs from now on, since I have shown almost all the ECGs for you. Then flutter of fib is serious. Both are serious. Now we are going to the treatment. Yeah. Treatment of this arrhythmia. So what are the treatment of this arrhythmia? So first of all, I'll give a simple logical approach. Later on, we'll discuss about what we have to do. So first, by the time you see, get the treatment, you will be knowing what is the probable diagnosis. So now you are going to split into an SVT. And you're going, before going into the treatment, let me tell first thing is to rule out sinus tachycardia. Before starting the treatment, always rule out sinus tachycardia, because in sinus tachycardia, you don't really need any antiarrhythmic drugs except ivabradine, that too in specialistic scenarios. Apart from that, you don't need really any drugs. So always rule out sinus tachycardia before starting the treatment. Then in this setting, next step is to find out whether the patient is in shock or not in shock. So see the stability of the patient. Ask the question, stable or not. If the patient is not stable, or if the patient is stable, yes. If the patient is not stable, then see whether pulse is there or not. So if the pulse is not felt in this setting, you can treat it as a cardiac arrest. So this is a true definition of a cardiac arrest if you are not able to see the pulse. So this is the actual definition of a cardiac arrest. So if the pulse is felt and the patient is unstable, which means the patient is in shock, systolic blood pressure. What is the definition of shock here then? The patient is having a systolic blood pressure of less than 90, if the patient is in syncope, or if the patient is having a myocardial infarction. In all these settings, this is suggestive of unstable nature. So this is not stable in this setting. If the patient is not stable, then you have to go for urgent synchronized DC cardioversion. That's really important. So cardiac arrest means you are going to follow the ACLS protocol, which we'll be discussing subsequently. So you are going to do something called that synchronized DC cardioversion. That's what we're going to do here. You know what do you mean by synchronized DCC? You are going to, for example, if you have a tachyarrhythmia, something like this going on, I'm trying to synchronize at the peak of the R wave. That's what I'm trying to do. So peak of the R wave. So this is the R wave and it's the peak. This is to avoid any inordinate R on T phenomenon. So suppose if your shock goes over the T wave, then it might degenerate into more worse arrhythmias like polymorphic VT and torsades. So we don't really want that to happen. So that is the reason why if a tachyarrhythmia is unstable, but still if you see the pulse, this pulse is going to decide your treatment. If you have a pulse, then you have to go for synchronized DC cardioversion only. If you have a cardiac arrest, then that doesn't matter. What more worse you expect in a cardiac arrest? So then it doesn't matter in that setting. So, I mean, you can straight away defib. You need not synchronize there. That's illogical there. Okay, anyway. So if the patient is stable, actually, in that particular setting, I have to see what is the type of arrhythmia. Whether I'm dealing with the supraventricular tachycardia or I'm probably dealing with the ventricular tachycardia. If I'm dealing with the ventricular tachycardia, then I have to ask another question whether it's a monomorphic VT or whether it's a polymorphic VT or whether it's a torsades. Whether it's a torsades. If it's a monomorphic VT, then I have to ask the question whether it's a fascicular VT or whether it's a non-fascicular VT, or for example, an outflow tract VT. If it's a fascicular VT, usually they respond to calcium channel blockers or adenosine itself. But adenosine response will be very poor. Most of the times, they will nicely respond to calcium channel blockers. They'll respond to calcium channel blockers. Okay, adenosine, or they will respond to calcium channel blockers. All right. Okay, then next, we are going to talk about a non-fascicular VT. Whenever you have a non-fascicular VT, see whether it is ischemic or a non-ischemic VT. Non-ischemic VT. If it's going to be an ischemic VT, then my first preference will be lignocaine. Lignocaine will be my first preference. For example, if the examiner gives you a post-MI related VT, then my first preference will be lignocaine in this setting. If it's a non-ischemic VT, then straight away, I'm going to use either a class 3 drug or probably I can use even a class 1A drug. Class 3 drugs, I can use amiodarone, I can use sotalol, I can use even ibutailide also, doesn't matter, but amiodarone and sotalol are very commonly used drugs. In that, amiodarone is an extremely commonly used drug. Class 1A drugs, I can use procainamide in this setting. So why in ischemic VT you are preferring lignocaine first? In ischemic VT, why you are preferring lignocaine is because they are selective for ischemic tissues, number one. First reason, they are very selective for ischemic tissues and depolarized tissues. And Rijo is asking difference between ischemic VT and VT with underlying structural VT. No, that cannot be diagnosed for the first time. So when the patient is already having an history, usually MI history will be there. Something will be there to tell it's an ischemic VT. Non-ischemic VT, best example is, for example, if you think about HOCM related VT or ARV related VT, in that setting, we'll take it as a non-ischemic structural VT. And in fact, post-MI VT is also a structural VT only. So, I mean, there is a scar in myocardial infarction. So that is also structural kind of VT only. You cannot differentiate based on that. But anyways, so it's selective for ischemic tissues. Apart from that, there's one more reason. It is less toxic compared to amiodarone. So that's why we prefer this drug. Suppose if this is not responding, then once again you have to move on to the class 3 drugs or class 1 year drugs only. Suppose if you don't have a good response with lignocaine. So in lignocaine, success rate is approximately around 20%, not more than that. Still, you can convert almost 1/5 of the patients with reduced side effects. That is the reason why you use lignocaine in this particular setting. But still, there is no response. Better to go for class 3 or class 1 year drugs, depending on your preference. And remember, out of all drugs, amiodarone has the highest success rate. Success rate of around 80%, which is highest among all the drugs. This is going to have the highest success rate, but it comes with a good bit of toxicity, which I have discussed already. Polymorphic VT, usually they will be unstable. As I told you, I think I have told you in the MI itself. Whenever you have a multifocal VPC itself, what I have told you, what point I have told you, when I told you some hyperacute ECG I have shown you, hyperacute T waves, I showed you in that, I showed you multifocal VPCs. So whenever I talk about multifocal VPCs, what does that mean? Whenever you have multifocal VPCs, what point I've told you? If anyone who attended the class very seriously should be able to tell. No. Whenever you have a multifocal VPCs, which means it acts from different areas, it indicates a very, very highly irritable myocardium. The same point I'm going to tell here. Whenever you have a polymorphic VT, means it's a highly irritable myocardium in the absence of TOSETs, that is long QT. If you have a polymorphic VT, that's a highly irritable myocardium coming from different focus you're having. Many times it will be some serious ischemia, serious hypoxia, something will happen. So that is why you get a polymorphic VT. Most of them will degenerate to death within a short period of time. So that's why it's better. It's very unlikely to be stable in the first place. Suppose if they are stable, by chance, always prepare for DCC, always prepare for shock. So even if they are stable, prepare for shock because they will definitely deteriorate somehow. But in the meantime, you can give either amiodarone or lignocaine depending on your choice. I'll prefer lignocaine if it's an MI patient who's coming with chest pain, or I can prefer amiodarone if you want efficacy more. So either of the drug you can prefer, but in the interim, always tell the staff nurse to get the defibrillator ready because they will anyway degenerate within short period of time. So TOSATs, if they are stable, you know magnesium sulfate is the usual treatment. Okay, I'll ask you one question. TOSATs means the moment you call TOSATs, you know it must be due to long QT. It's a type of PMVT only, but it's a type of long QT only. Suppose if you get this because of long QT, naturally get the basics that I have told yesterday. So if you have a like higher heart rate, you will get long QT, or if you have a lower heart rate, you will get a long QT. Where you will get long QT? You'll get a higher heart rate, you will get a long QT, or lower heart rate, you will get a long QT. At a lower heart rate. So this is where you're going to get a long QT, right? At a lower heart rate only, you'll get a long QT. Higher heart rate, your QT is going to reduce. I'm writing low heart rate, correct only, but you'll get a long QT here. At a higher heart rate, you're going to get a shortening of QT only, which means TOSATs that is happening due to a long QT, it's an arrhythmia only, I'm not telling no, but it should have happened at a lower heart rate. That's the key. Suppose any arrhythmia that is happening at due to long QT will happen at a lower heart rate. That is the basic take-home point that you need. So TOSATs has happened. That's a tachyarrhythmia, all right. But it should have happened at a lower heart rate only. So to prevent that the lower heart rate from happening, once you have cardioverted with magnesium sulfate, it is better to start with pacing. You have to start with the pacing. So many students will be confused here. So why we have to pace? Because I assume whenever I get a TOSATs, it must be a lower heart rate related tachyarrhythmia. So at a lower heart rate, because I have induced an EAD, and there is a lot of chance that our antiphenomenon would have happened and that would have triggered an arrhythmia. So to prevent the next arrhythmia from happening, I will usually start at the pacing with my target heart rate of approximately 100 per minute. So many students will be highly confused, like for a tachyarrhythmia, why should I pace? Is there any, is it stupidity? No, it's not stupidity because TOSATs is likely to happen at a lower heart rate only. So that's why I'm trying to pace, keep a heart rate at 100 within the ICU so that to prevent the next attack of TOSATs. That's the idea. So magnesium sulfate, fine, but this is also a very important question. Pacing is one of the important treatments for TOSATs where I can pace and keep the heart rate at 100 beats per minute. to prevent the lower heart rate from producing long QT again from causing tachyarrhythmia again. So this is how you're going to treat a ventricular tachyarrhythmia. So now go for the supraventricular tachyarrhythmia. SVT, the most important SVTs are probably AV NRT, and we have AV RT, that is AV reciprocating tachycardias. Then we have, what else? We have flutter and fib. If you know fib, that's enough, because the treatment is almost same as that of the flutter. I mean, not like that. The flutter treatment is almost same as that of the fibrillation, because we don't have any much evidence for a separate flutter treatment. We just extrapolate the fibrillation treatment to flutter treatment also. AVRT, we know if it's probably an orthodromic conduction, I'll be using AV nodal blocker. If it's an antidromic conduction, I'll be preferring a sodium channel blocker. So this is the rule in general. You can apply the same for exams also. If you don't have sodium channel blocker option, then you can go for some AV nodal blocker. So this is a common rule for practice: AV reciprocating tachycardia or AVRT. Of course, your long-term treatment will be radiofrequency ablation. This is the definitive treatment in the setting of a AV reentrant tachycardia or AV reciprocating tachycardia. Of course, when you have an AV NRT, the first choice treatment I'm going to try is vagal maneuvers, because vagal maneuvers are very powerful AV nodal blockers. Vagus is a very powerful AV nodal blocker. So once my vagal maneuvers are not, because success rate with the vagal maneuvers is only 10 to 20% depending on the expertise and skill. So still 1 in 5 patients will respond just by compressing the carotid sinus. That's called carotid sinus massage. Just by pushing the carotid sinus, you are going to get the arrhythmia terminated. That's cool, isn't it? Unilateral is still more than enough. Why you want to do bilateral carotid massage? Unilateral is enough. So first is vagal maneuvers. If it's not responding, then I'll be moving to drugs. So what are the drugs I'm going to use? The first line drug is, of course, adenosine. That's the first line drug. So adenosine, in the sense, you have to know the dose of adenosine. That's really important. The first dose I'll try is 6 milligram. If it doesn't respond, second dose I'll give 12 milligram. And if it doesn't respond, third dose I'll give 12 milligram. So the total dose I can use is approximately around 30 milligram. Practically, yes. I mean, what are the vagal maneuvers? Why you feel it's very difficult to use? Because AVNRT is such a benign rhythm. Most of the times it will be very benign rhythm. And the only symptom of the patient will be palpitations. That's how they come. It's most of the time it's a very benign rhythm. So how you do vagal maneuvers? You are just going to do a carotid sinus massage, CSM, or you are going to OPD while valve. I'm doing massage for PSVD. Okay. Okay. Carotid sinus massage, or second, you are going to use Valsalva. Cold water on face. Don't do this kind of things and all. Are you doing any cinema shooting there? If it's a girl, you pour cold water on her face and you drench her, and you can actually do for a shooting for a romantic song. We are not doing that. So why you want to pour suddenly cold water on her face? This is an extreme level of thinking, isn't it? Pediatric is fine. We are talking about adults here. Pediatrics, I don't know really whether you throw cold water on face or not. Even there, I don't think they will agree to all this kind of things. I have never read that. I'll go and read again. Cold water will activate vagus, fine, but I don't know. So Valsalva. Valsalva is there. So Valsalva, how will you do Valsalva? Just ask the patient to strain. You ask the patient to strain as if he has not passed stools for 3 days. Like how will you strain in the bathroom? No, like that's how you strain. So that's Valsalva. So do Valsalva. So it's very easy to do. So if it doesn't get resolved by that, then you're going to go for drugs. Of course, the first line drug is adenosine. The dose is 6 plus 12 plus 12. You're going to give 30 milligram of adenosine. Total, this is the maximum dose of adenosine. And remember, adenosine's half-life is extremely short. It's only some 7 to 15 seconds is the duration of action and the half-life. So which means it has to be given as a rapid and extremely rapid, fast IV push. For that, usually we prefer an external, not internal, external jugular vein, just a venflon, just a IV cannula is enough that you put here, or minimum you put in the cubital vein. Don't try in this distal vein. So that before it reaches the heart, it will be taken up by the endothelium and the effect will be lost, because adenosine is rapidly taken up by the platelets and the endothelium. So its effect will be lost even before reaching the heart. So put it in the cubital vein and push the saline very fast. You're going to do something called a rapid IV push. So push adenosine, immediately you push a bolus of 10 ml of normal saline or distilled water, so that it reaches the heart very rapidly, so that in many of the times even we keep the hand up, because by gravity it goes very fast to the heart. So it has to be given as a very rapid IV push. And the mechanism of action, we know how adenosine works. It's going to be cause hyperpolarization of the AV node, AV nodal hyperpolarization by opening up the ATP sensitive potassium channels. That's what we're going to do. Adenosine, ATP, both has some relation. So they're going to open up the ATP sensitive potassium channel. So they are going to cause hyperpolarization of the AV node. Once they cause hyperpolarization of the AV node, you can result in reduced, yes, it's a bronchoconstriction. I'll come back to that. So hyperpolarization means if you have the resting membrane potential and the threshold potential here. So now your resting membrane potential after adenosine will become something like that. So it becomes very difficult to reach the threshold potential. So that's all. So this is how you give adenosine. So it's a mechanism of action, AV nodal hyperpolarization by opening up the potassium channels. Then what else you have? Yes, and side effects. Side effects of adenosine, bronchoconstriction, very important side effect, of course. So that some patients may not be eligible for adenosine. Suppose if you don't have a good response to adenosine, I mean, it's not like you don't get a good response. Most of the times, adenosine will never fail, according to me, because only the type of giving adenosine. For example, your method of giving adenosine is a problem. Adenosine causes ventricular fibrillation. Rijo is asking. Actually, it's been thought that it can cause, but I don't think so. But sometimes, if you're giving in a VT, sometimes it can degenerate to ventricular fibrillation. In that setting, if you're giving for a VT, but of course, we are not going to give adenosine for a full-blown monomorphic ventilator tachycardia unless and until if it's a fascicular VT. So, I mean, for a VT, generally we don't give adenosine. We give only amiodarone or lignocaine, but that's different. It can cause a VF, yes, but especially in a patient who's having a ventricular tachycardia, not in a AV and RT. So bronchoconstriction. So some patients may not be eligible. For example, if adenosine is not available, or if adenosine is contraindicated because the patient is a severe reactive airways disease patient, in that setting I can go for alternative drugs. These are second-line drugs. That is beta blocker and calcium channel blockers like verapamil and diltiazem. Remember, dipins, your amlodipine and nifedipine and all this stuff are basically not going to have any antiarrhythmic potential. They cannot block the AV node, but verapamil and diltiazem, these are non-dihydropyridine calcium channel blockers. They have AV nodal blocking property, but only verapamil and diltiazem. So final, but last but not the least, the definitive treatment once you have treated is radiofrequency ablation. That's the definitive treatment of AV and RT. Apart from that, first line drug is always adenosine. Second line drugs, you can use either a beta blocker or a calcium channel blocker. When will today's class end? Maybe in half an hour, 45 minutes. Okay. So this is how you treat an AV and RT. So even if they ask in pregnancy, suppose if somebody asking you in pregnancy, what is the treatment basically in an AV and RT, still the answer will be adenosine. Even though we don't know the adenosine effects on the fetus, but still we are very sure that adenosine is not going to cross placenta, because before it crosses the placenta, it will be gone because of the very, tomorrow sometime I'm going to continue cardiology. Don't worry. If the portion is not complete, I'll be anyway extending the sessions. No problem about that at all. So no need to worry. Anyways, so this is how you treat an AV and RT. AV-RT treatment once. You have been asking continuously orthodromic AV nodal blocker, antidromic sodium channel blockers, definite treatment, RFA. I told you multiple number of times, even during the Wolff-Parkinson-White syndrome in the morning. So atrial fibrillation will be treated the same as atrial flutter, but let us see the atrial fibrillation first. So before starting treatment, the most important thing, can anyone tell what is the most important thing before starting treatment? No, rule out pre-exit AF. That's very important, because the treatment you are going to give is AV nodal blockers. So the first thing that you have to do is make sure that it's not a pre-exit AF. It's not a Wolff-Parkinson-White syndrome and atrial fibrillation. So be very, very sure about that. So once you have ruled out a pre-exit AF in the ECG and you are sure it's a ordinary atrial fibrillation only, Now you're going to start with something called as RACE. So RAC. So R literally stands for rate control. That's the first idea. So rate control depends on whether the patient is having heart failure or whether the patient is having no heart failure. Of course, if the patient is having heart failure, I'm going to use DIG. If the patient is not having heart failure, I'll be using either a beta blocker. If it's contraindicated, already I told you the beta blocker contraindications, I'll be using a non-dihydropyridine calcium channel blockers like verapamil or diltiazem. But here adenosine has no role. Even though adenosine is an AV nodal blocker, it has no role. Remember, you have a mnemonic for AV nodal blockers. You have A, B, C, D. A stands for adenosine, B stands for beta blockers, and C stands for non-dihydropyridine calcium channel blockers, and D stands for DIG. So these are the 4 drugs that can block the AV node. So remember, that's why I told you in the beginning itself, you have to rule out pre-existing AF because none of the AV node blockers should be given in pre-existing AF. Otherwise, you will kill the patient and you'll convert AF into VF, literally. And that's why if the patient is in heart failure, digitalis, I told you multiple times in the morning itself, if the patient is having AF with a heart failure, digitalis becomes one of the very, very important drugs in that setting. That's where digitalis is commonly used as well. More than heart failure, AF with heart failure is the place where we use digitalis. Then A, you know what A stands for? A stands for, of course, anticoagulation. And C stands for cardioversion. Let me write C here itself. So anticoagulation, how you will give, you have to see the duration of atrial fibrillation. So whether it is less than 48 hours or if it is more than 48 hours, acute or chronic, or if the duration is unknown. The duration is unknown, it will be taken as a chronic AF only. So if less than 48 hours, then in that setting, you have to see the Charts-to-VASc score. I'll tell you what is Charts-to-VASc. Once you see the Charts-to-VASc score, if it is going to be 0, then you don't need of any anticoagulation. These patients are special group of patients which I'll discuss. If it's more than or equal to 2, then definitely you need something called a mandatory anticoagulation. You need something called a mandatory anticoagulation. You have to start with anticoagulation for sure if the Charts-to-VASc score is more than or equal to 2. Suppose if the patient is having AF of more than 48 hours, then in this setting, straight away I'll start with the mandatory anticoagulation, because if the AF has been there for more than 48 hours means there's a lot of chance that the patient would have developed a clot at this point of time. So it's better to start with the mandatory anticoagulation. So here Charts-to-VASc score is not important. Even if the Charts-to-VASc score is 0 also, if the AF is more than 48 hours, you can you have to go for mandatory anticoagulation. Suppose the score is 1, what you will do, I'll tell you later on. So I'll tell you once I'm going to, start about the Charts-to-VASc score, that time I'll tell you what you will do for a score of 1. If the patient has coagulation abnormality, what kind of coagulation abnormality you are thinking about? If the patient has coagulation abnormality, then why they should develop a clot in the first place? Von Willebrand disease. That's a minor. Still, you will start. I'm talking about a major coagulation problem, like, for example, patient with a liver disease with the INR of 2.8 or 3. So in that setting, I generally don't start with anticoagulation. But minor coagulation abnormalities, I don't really care. I generally start with anticoagulation unless until there is a serious bleeding. That's why there is a separate entity is there. So you have something called a Has blood score that has to be looked for. So, the one problem with this score is this score, if you use, will not tell you whether to use anticoagulation or not. This score will tell you only the risk of bleeding associated with anticoagulation. So again, depending on the risk, it's your clinical decision to tell whether the patient should be used with anticoagulation or the patient should not be used with anticoagulation. If you have any doubt, you can go towards, go to the home and you can study this Has blood score once again and find out the risk, whether it is there or not. And again, Has blood score is not very useful because it will not dictate my treatment. It will only tell you what is the risk of the patient to have a bleeding. So if the Has blood score is very high, I can assume that the patient's risk is very high for bleeding. So I will probably think of a lower dose of anticoagulation, or if my practice, I'm having a lot of experience, then I can even skip the anticoagulation. But Has blood score has not told any proper clinical guideline. So mandatory anticoagulation, all right. So what is the ways to give anticoagulation? So how you can give anticoagulation? Either you can give in the form of your warfarin, or you can start with Novax. Those are novel oral anticoagulants. Previously I've told you multiple times about the novel oral anticoagulants. There are many entities are there. The 4 most commonly used novel anticoagulants are dabigatran, Then that is Pradaxa. The Vigatin is Pradaxa. Then we have Dabigo also. Then we have Apixaban, Eliquis. I'm writing both together. Apixaban. Then we have Rivaroxaban. Then we have Edoxaban. So these are the 4 NOACs. Novel oral anticoagulants. Warfarin is an old oral anticoagulant. These 4 are novel oral anticoagulants. So warfarin, one problem is you have to start with heparin and then you have to start with warfarin. So which means you have to bridge both together, and once the INR becomes 2 to 3, then only you can start heparin and continue with warfarin. So you have to wait till the INR becomes 2 to 3 and stable at least for more than 24 hours. So then you can stop heparin and you can continue with warfarin. Continue warfarin. As far as the AF treatment is concerned, Novax doesn't need any bridging. Straight away you can start. As far as AF treatment is concerned, you don't need any bridging here. No bridge. Straight away start with Novax. That's one bigger advantage. So Novax is immediate. And remember, you have to wait. As far as warfarin is concerned, you have to wait till the INR becomes 2 to 3, and you have to wait for another 24 hours, and it should be stable. Which means total it will take around 5 to 6 days. But Novac can achieve anticoagulation within 12 hours. Within 12 hours, you can achieve full anticoagulation with Novax. So that's a big advantage of Novax right now. But one important thing that you have to note about Novax is it is currently approved only for non-valvular atrial fibrillation. It is not approved for valvular atrial fibrillation. Which means if your AF is due to some valvular defect like MR or MS, then Novax cannot be used. That's not approved yet. And second, it's not good for APLA patients. So suppose if the patient is having a valvular AF, or if the patient is having APLA, antiphospholipid antibody syndrome, in both these settings, it's better to always use a warfarin where it is having a higher evidence. But remember, warfarin can also be used in non-valvular AF. It is not like warfarin cannot be used in non-valvular AF, but the choice is Novax. If it's a non-valvular AF, the choice is always Novax only. So once you have achieved the full anticoagulation, remember, somehow now you have achieved anticoagulation. So which means by giving either warfarin, you have achieved INR of 2 to 3, or Novax, you are achieved anticoagulation within 12 hours. APLA is antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome. Okay. So now, Harita, which you are in? Just a doubt. UG. Okay, I don't know which you are in, but anyways. Applies antiphospholipid antibody syndrome. And please don't break my heart by telling first year or second year. Okay. So, non-valvular AF. You can use Novax. That is preferred in that setting. So once you have achieved anticoagulation, now your idea is to whether to do cardioversion or not. Cardioversion is nothing but converting the arrhythmia to sinus rhythm is what we refer to as cardioversion. So whether you'll do cardioversion or not depends on the availability of TE. Transesophageal echo is available or not. So if my center has, yes, transesophageal echo is available, then rule out a clot. Rule out a clot. And once you rule out a clot, straight away you can go for cardioversion. No problem. My center does not have a TE. So in that setting, I cannot do cardioversion. In that, I have to, mandatory give anticoagulation. Again, I have a mandatory phase of anticoagulation for at least a period of 3 weeks. Then only I have to go for cardioversion if my TE is not available. So that's why if you have a TE, it's a huge advantage. You can straight away go for cardioversion once you have ruled out a clot. If there is a clot, then you have to wait till the clot is lysed. What is the use of time? Can't understand the role of treatment. The idea is if it's more than 48 hours, then definitely there will be a risk of clot formation. If it's less than 48 hours, then the clot formation will be dependent on a risk based on Church-Tugas score. That's the idea. If it's more than 48 hours, then it's a sure shot risk of clot formation. There's no doubt about that. That's the idea. AF is coming unstable. Then follow this algorithm. Come here. If the AF is unstable, then either go for cardiac arrest ACLS algorithm or go for synchronous DC cardioversion. That's all. So only if they're stable AF, you're going to do all this nonsense. So idea is you're going to give mandatory anticoagulation. What we are thinking is in a 3-week of anticoagulation period, even if there was a clot, we are thinking that that clot would have melted by now in 3 weeks time. So that's why we wait for 3 weeks, give anticoagulation, then you can go for cardioversion. So that is what we are going to discuss next. So CE. So what race? In race, CE stands for cardioversion. And there are 2 types of cardioversion, electrical and chemical, but electrical cardioversion is preferred than chemical cardioversion. Electrical is always better, best, and it is having low side effect and comparatively faster response. So but if you want to use a chemical cardioversion, what kind of chemical cardioversion you are going to use? Either you can use a class 3 drug or I can use a class 1C drug. But if they ask you the most effective drug, it is always class 1C. That's supposed to be the most effective with a success rate of almost 80 to 90% in the first attempt itself. So class 1C is effective. But one problem is it can be used only if there is no structural heart disease. Because most of the patients with AF are having left atrial enlargement and underlying structural heart disease, usually we prefer class 3 drugs only. That's the common practical thing. But 1C drugs can be used if you are very sure that there is no structural heart disease. All the class 3 drugs are effective. And you can use amiodarone, you can use sotalol, you can use even ibutilide or dofetilide. You can use dronedarone also. That's also fine. Ibutilide, dofetilide. Among these class 3 drugs, if they ask you which is effective, ibutilide is supposed to be a little effective compared to that of the other class 3 drugs. But anyways, whatever you can use, no problem. So now you have cardioverted. Now there are 2 options. Once you have cardioverted, what is the fate of atrial fibrillation? You have attempted cardioversion. Now the fate of atrial fibrillation may be either successful cardioversion or AF being a very resistant rhythm. Sometimes it can fail. So if it's failed, then there's no other option. You have to continue the rate control and anticoagulation. Just continue with it. Continue rate control anticoagulation indefinitely till the AF gets back to sinus rhythm. That's all. Or you can attempt do a next attempt of cardioversion maybe later on. If the patient got a successful cardioversion, which means patient has converted back to sinus rhythm. Now there are 2 questions you have to answer. What you will do with the anticoagulation? Number 1. What you are going to do with the anticoagulation? That's the first question. And the second question is, AF is known to come back again, and how you are going to treat. So if you are having, anticoagulation in the sense, first, number 1 thing you need to know that even after cardioversion, there is a mandatory again period for at least 3 weeks. You need to give mandatory anticoagulation. You might be asking, we've already cardioverted, why you have to give something called a mandatory anticoagulation? There is something called post-cardioversion stunning. For example, especially in patients with AF, especially atrium is more problematic because when you cardiovert, that shock itself can produce something called a post-cardioversion stunning, even though the depolarization is happening. But the atrial myocardium will not contract properly. Still, there is a risk of clot formation even after cardioversion. So that is the reason why it's better to use something called a mandatory anticoagulation. At the same time, to start with, AF was there in the beginning. So there could be a micro clot that would have been formed already that could expand over a period of time. So that is why it's better always to continue 3 weeks of mandatory anticoagulation. Even after cardioversion, that's a very important point. After these 3 weeks, further choice, further anticoagulation or future of anticoagulation from this point after that initial 3 weeks of mandatory anticoagulation will be dependent on the CHADS-2 score. So the score is more than or equal to 2, continue indefinite anticoagulation. The score is 0 or 1, I'll tell you what to do. 0 means definitely no. If it's more than or equal to 2, then you'll be doing indefinite anticoagulation in that setting. Second question that you need to answer is how you're going to prevent the recurrence. Because AF is supposed to come back again, how you're going to prefer recurrence. If the AF, to prevent the AF coming from recurrence, you have to give some prophylaxis with some anti-arrhythmic drugs. So class 3 drugs are the best for this purpose. Class 1 are also okay, but it's not that good. Class 3 are the best. In the class 3, amiodarone is supposed to be the best for preventing the recurrence of AF from happening again. But apart from that, you can use sotalol or you can use tofetilide also. All these drugs can be tried, but amiodarone is the usual standard of care. It's going to be one of the best drugs for this purpose. So this is to prevent AF from happening again. So that is to maintain AF in maintain the patient in sinus rhythm. If they ask you what is the drug that you'll use for maintaining the patient in sinus rhythm, my choice will be amiodarone, of course. So what will you do in these patients? In these patients, if you have a rate control, I mean, there's a failed cardioversion, and you have tried multiple attempts, it has failed and has gone for either a long-standing persistent AF or a permanent AF. Now you are in a situation where it become a long-standing persistent or a permanent AF. So now in this setting, there are two options. Either you can continue rate control and anticoagulation, plus or minus rhythm control, depending on the patient selection. But the most important is the rate control and anticoagulation. Rhythm control is not needed here because, rhythm control cannot be done, because you have not cardioverted, you cannot cardiovert. So you have to continue the rate control anticoagulation indefinitely for lifelong. That's one option. Second, you are going to do some surgeries. You can try surgeries. For example, the most important surgery is like you can, depending on whether you need a rate control or rhythm control. If you want a rate control, that's a major problem there. Riju is asking E stands for electrical cardioversion is better than chemical cardioversion. I told you already. Okay. So if you want a rate control surgery, you can do something called AV nodal ablation. AV nodal ablation. So you know very well in an atrial fibrillation, the fibrillation rhythm is here and the AV node is here. If the patient wants to get a higher rate, suppose if the ventricular response is high and you badly want a rate control, means ablate the thing that translates the atrial fibrillation rhythm into the ventricles. So now the ventricular response will reduce, but it might go for a bradycardia. So that is why you have to pace this ventricle as well. So this is what we refer to as ablate and pace strategy, or otherwise referred to as AV nodal ablation and pacing. Suppose if you want rhythm control, which means the patient is in such a situation, they want rhythm control only. In that setting, we can do something called a pulmonary vein isolation. Or your idea is to reduce the clot and thromboembolism, not reducing the clot, reducing the thromboembolic manifestations. Remember, AF is the most common cardiac cause of causing an embolic stroke. Most common cardiac cause of causing an embolic stroke. If you want to reduce the thromboembolic manifestations, then there is another surgery called left atrial appendage occlusion. There are a lot of devices that can occlude the left atrial appendage. So if you want to reduce the thromboembolic episodes, then you have to do something called a LA occlusion, that is left atrial appendage occlusion surgeries. So I think we have covered the algorithm for tachyarrhythmias, how to manage each and every tachyarrhythmia. So this is a very wonderful flowchart which will cover everything, each and everything, how to cover. But a nutshell, when things are very simple, this is a final take-home point. Narrow complex, AV nodal blockers, wide complex, sodium channel blockers. That's all. Finish. That's all. Final, this is the nutshell that you need to know. Narrow complex tachycardia means after ruling out sinus tachycardia, it is a AV nodal blocker. And if it's a wide complex, go for sodium channel blockers. This is the final nutshell that you need to know. So you might be arguing that if it's a VT, what you will do? VT will be wide complex only. But there are some VTs which can be fascicular, where still they will respond to AV nodal blockers. But in this condition, if you are doing fascicular VT, you are going to use only calcium channel blockers. They are going to work very well. I mean, if in doubt, you can give amiodarone also. Even amiodarone is also calcium channel blocker. It will work there. Chats to 1. Vijay is asking bleeding on warfarin, how to manage. He wants to know the practice points. Depends, Vijay. For example, if the patient is on warfarin and gets a bleeding, there are two situations where you'll encounter. Either you can get a bleeding, or you can just have increased INR without bleeding. The idea is very simple. If there is a bleeding, whether it be minor or major, previously there was categorization like minor bleeding or major bleeding. If it's whatever may be the case, if it's a bleeding, you have to urgently give IV vitamin K. Usually we give 5 to 10 milligram of IV vitamin K immediately, and you have to repeat it. Plus at the same time, because IV vitamin K will take, it's an antidote for warfarin, but still it will take some time to act. So immediately to replace the clotting factors, you need to use something called a 4-complex PCC. So that is prothrombin complex concentrate. Because vitamin K inhibits the clotting factors 2, 7, 9, and 10, we are giving this 4-complex PCC, which contains this factors 2, 7, 9, and 10. So that's a very specialized concentrate. That's a prothrombin complex concentrate that contains factors 2, 7, 9, 10. Suppose if this is not available, we have a poor man's 4-complex species, that is FFP. FFP is a poor man's 4-complex PCC. So if it's not available, then you can prefer an FFP. That's all. So if the patient is having only increased INR without a bleeding, then you have to see what is INR. Suppose if the INR value is more than 8, so in this setting, you can give oral vitamin K. If the INR is somewhere around 4.5 to 8, you can give, probably you can wait and you can skip 1 to 2 doses. Skip 1 to 2 doses of warfarin, and you can review the patient again and with the repeat INR. Suppose if INR is less than 4.5, you can continue warfarin plus reassess later on. Reassess later on. That's all. And at the same time, whatever may be the case of elevated INR, doesn't matter. Whatever may be the case of elevated INR, it is like you have to evaluate for drug interactions, because whenever you have an elevated INR, many times it will be due to some drug interaction, because given grapefruit juice can alter the INR if the patient is on warfarin. So you have to evaluate always for the drug interaction. The patient is probably taking any potential drug that can increase the warfarin action. So that's what we have to do. So this is how you manage a warfarin. And if you're asking whether it is important for exam or not, this 4-complex PCC has been asked many times in the exam. So what is the best treatment for warfarin-induced bleeding? It can be anything. So this is how you manage a warfarin-induced bleeding, basically, if you are really worried about that. The next step, next thing what we're going to discuss is, what is that? Yeah, people are asking about the CHATS-2-VAS score. CHATS-2-VAS score. CHATS-2-VAS score, it stands for C stands for CHF, and H stands for hypertension. A stands for age. Less than 65 means 0 points. 65 to 74 means it carries 1 point. Anything more than 75 carries 2 points. CHF 1 point, hypertension 1 point, and D stands for diabetes mellitus, which carries 1 point. And S2 means you have 2 S. One is, why it's called S2, because stroke and TIA, the patient has, it carries 2 points. That's why it's called CHATS-2. And if the patient is having other vascular diseases, any other vascular disease, like coronary artery disease or peripheral vascular disease, these are other vascular diseases, they carry another 1 point. So that's all. So clear? So total score 1, 2, 3, 4, 5, 6, 7. So you might be thinking, 8. So you might be thinking that 8 is the total score, but no, there's one more thing. Yes. Females by default carry 1 point. I don't know why this fellow has high affinity for females. Females by default carry 1 point. And that there is a very important thing to understand in that, I'll tell you. So the total score is not 8. The total score is always 9. It's not 8, because females by default will carry another 1 point. But the guidelines are very clear. Suppose if the score is 0, there's nothing to do. You can start with anticoagulation. No doubt. I think I am little hungry. So if the score is 0, do nothing. Do nothing. No need to do anticoagulation. If the score is more than or equal to 2, then it's mandatory that you start with some form of anticoagulation for sure. No doubt about that. But the score is 1. This is where the problem is. So what they're telling is, see whether this score of 1 is purely due to the female sex. If the score of 1 is only due to sexual reasons, only due to that the patient is a female, then in this setting, no need to start anticoagulation. No need, really. That's what it's been clearly given in the guideline. The score of 1 is achieved just by virtue of their sex. Just being a female, you get a score of 1. No need to start. Otherwise, you can start anticoagulation. That's what they're telling. So 1 is a little confusing. So if the score of 1 is achieved just because the patient is a female, you can you need not start with anticoagulation. But if the score is 1, then you have to start with anticoagulation. If the patient score is 1, not because of female. Yeah, that's an old idea. Pranav is asking whether you'll give aspirin or not. That's an old idea to start whether aspirin or not. That's gone 2 years back. They used to ask this score of 1. For this score of 1, you can choose whether aspirin or warfarin. But currently the guidelines are telling still the choice is always stronger anticoagulation like warfarin only. Or any NOAC can be used. So if not warfarin. So aspirin is not preferred in the setting of an AF usually. It's been told to have a very poor evidence. And many studies have proved that the patient will get thrombus despite taking aspirin. So it's always start with a proper anticoagulation like warfarin or heparin. So I think that should solve the issue, isn't it? But one more thing which I'm not told is these patients who have a Tacharrhythmias score of probably 0, and we have not discussed about these patients. Tacharrhythmias score of 0. Tacharrhythmias score of 0. We have not discussed about these guys, which means what I told you is no need of anticoagulation, but I didn't tell no need of any treatment. So of course you have to give some treatment. What treatment you are going to give? You can directly cardioversion. You can go for directly. I should not write direct cardioversion. You can straight away proceed towards cardioversion. Otherwise, you'll ask what do you mean by direct and indirect. So proceed towards cardioversion in this setting. So which means these guys are elite group of guys. If the duration is less than 48 hours, Tacharrhythmias is 0, then no need to anticoagulate, no need to give red control. Straight away proceed to cardioversion. Very elite group of drugs, elite group of guys, isn't it? So no need to do anything. It's immediate therapy. If I'm having a AF, maybe onset 3-4 hours before, which I'm very sure, I'm a medico, I'll be 100% sure that I got AF only 3-4 hours back, and I'm going to the hospital, and I am a patient with no risk factor. My Tacharrhythmias score is 0. Make them lie down, give a little bit of propofol or midazolam, put the leads, cutaneous leads, and cardiovert. That's all. Shock. I mean, it depends again. If they want to give flecainide to me, then that's fine. That's also fine. But shock is more effective compared to that of all these drugs. Why you need red control? Remember, why you do cardioversion basically? Rijo is asking why we don't want red control. Tell me why you do cardioversion in the first place. That will answer your question. Tell Rijo why you do cardioversion. Why you do cardioversion? To regularize the rhythm, not regularize the rhythm. Regularize the rhythm means to what rhythm you are bringing back the patient to. Answer the question. To what rhythm you are bringing the patient back to? Sinus rhythm. If it's sinus rhythm, you don't think it's a controlled rate? Yes, that's all. So why you are not doing cardioversion then there? Because in that patients whose this kind of patients are having more than 40 of the Tacharrhythmias score of more than 2, the patient would have had a clot. So if you do cardioversion straight away in those patients, it would be a problem. That's why you are going like this, doing a rate control and then going for anticoagulation cardioversion. So if the patient is not having any risk factor for clot and Tacharrhythmias score is 0, touch like this, straight away cardiovert them. That's all. No need to worry about that. So proceed to cardioversion. So this is also the basis of something called as a pill in the pocket strategy. So what do you mean by pill in the pocket strategy? So which means for this, the drug of choice is class 1C. So to know I mean, the patient is having no structural heart disease, number one. The patient is having no risk factors, and the patient is having Tacharrhythmias score of 0. Tacharrhythmias score of 0. So, and this patient should be a little young, and they should be getting paroxysmal AF, paroxysmal and recurrent AF, and it's troubling the patient also. And the patient should be educated to know when to take it. So, in these patients, you can try this flecainide or propofenone pill in the form of something called a pill in the pocket strategy. So what do you mean by that? So if I am the patient who's suffering, I'm young, educated, I know to check my pulse rate, but I'm getting recurrent paroxysmal AF, but occasionally, not very frequently, occasionally I'm getting paroxysmal AF, which is actually troubling me. I'm getting palpitations and a lot of anxiety-like attacks. So they do an echo. I don't have any structural heart disease. I don't have risk factors, no diabetes, no problem. Tacharrhythmias score for me is 0. So what my doctor is going to say, so look, whenever you get palpitation, just check the pulse rate. If you feel that the pulse is irregular, take the propofenone or a flecainide pill and swallow, sit for 5 minutes, see the pulse again, regular, start doing your work. So that is again is an extrapolation of this acute AF that is going to happen with a Tacharrhythmias score of 0. It's just an extrapolation of that. So that is called as a pill in the pocket strategy, where you can going to use characteristically these class 1C drugs only. That's all. So I think the entire thing about atrial fibrillation is completely done. There's nothing else that we need to really work upon as far as tachyarrhythmia treatment is concerned. Clear? So this must be more than enough. So you'll be seeing everything in this tachyarrhythmia treatment. So I think in exam, whatever may be the tachyarrhythmia, you'll be easily able to answer. No problem. Finally, it's done. You have understood the arrhythmias. Then I think still I have some more to complete. Tomorrow I'll do cardiology. So no problem. Otherwise, I mean, if there is no time, I'll extend the sessions. Maybe in October 1 or 2 later on. Atrial flutter, same treatment. I told you, literally the same treatment. We don't have real good evidence for treating atrial flutter, but like same treatment. Whatever I told you, it applies for atrial flutter also. It's just an extrapolation of the same treatment. There's no much bigger treatment for atrial flutter separately. If you want, I will complete the ACLS algorithm, that is cardiac arrest algorithm. If you don't want, I'll start tomorrow. Okay. Deepika wants it. So I'll start with cardiac arrest. Let's 2 minutes. Just start with cardiac arrest. So many people are telling, okay, we can start. 2 minutes, we'll finish. So first we need to know when is a cardiac arrest. So for example, whenever the patient is coming with a collapse, so straight away you should not jump into cardioversion. Or straight away don't jump into a CPR. If the patient is suffering from a collapse, first check whether they are responding or not. So that's the next thing. So that's a common thing you do. Whenever in your home also, if somebody collapses, you check, like, how are you? Oh, what happened to you? Get up. That's what the practical thing is. So check for responsiveness first. Once, if they are responding, then it's okay. No need to do CPR. Just take them to the hospital and check why they have collapsed. Or if you are in the hospital, evaluate for the cause of collapse. The patient is not responding, little dangerous. Now we have to check for the pulse. It could be a cardiac arrest. If the pulse is felt, then again, okay, it is not a cardiac arrest, but still start evaluating why the patient has got a collapse and they are not responding also in this setting. So you have to definitely evaluate for that. It could be something else like a seizure or even a stroke. We really don't know. We have to evaluate for that. So if the pulse is not there, then you are in a state of true cardiac arrest. So this is definitely true cardiac arrest. If they ask you which pulse to really see, I'll be typically going for a carotid pulse. So that's where everyone has to be trained, even in the BLS step. So idea is to tell whether the pulse is felt or not felt. It's not like the pulse is feebly felt, humbly felt, or nicely felt. There's nothing grading like that, felt or not felt. If you're not able to feel, it's like a cardiac arrest only. So this is where you straight away jump and start the CPR immediately as soon as possible. It depends. For example, if they ask you chest compressions to the rescue breath ratio, so usually in adult patients, it's standard always. It's around 30:2. That's the standard ratio. For example, if it's a child, that's a pediatric age group, then it depends. It can be 30:2 or it can be 50:2 also. So if the number of rescuer is 1, then you can use 30:2 ratio. If the number of rescuers, if the number of people surrounding you is more than or equal to 2, then it is 15:2. Then if the child, if the thing is extremely neonat, like it's extremely low age, it's like a neonat going for cardiac arrest, in this setting, the ratio will be 3:1. So it depends. For adults is what examiners will ask. So it's always 30:2. That's for adults. Clear. So now you're starting to do with the CPR. Suppose if they ask you what is the most important component of a CPR, this is a very common question in majority of the exams. Suppose if they ask you the most important component of CPR, I'll always go for chest compression. Chest compressions is very, very important. That's the reason why they have changed the ABC in 2010 to CAB in 2010, where C stands for circulation, A stands for airway, and finally your breathing comes, which means the chest compressions are given the highest priority in the ACLS and cardiac arrest algorithm. They are the most important component. So you need to have a good quality of chest compressions. As of the basic life support is concerned, the chest compression should be made sure that at least it's at a good rate of 100 to 120 per minute. Remember, you should not give it a more rate, or you should not give it a lesser rate also. It should be at an exact rate of 100 to 120 per minute. That's the good quality chest compression. Remember, for example, if you're compressing extremely fast, maybe at a rate of 300 per minute, you might be thinking that you're compressing very nicely, but then what is the difference between you and a ventricular tachycardia? Both are doing the same thing. So don't do at 300 per minute or 250 per minute. So give at an exact rate of 100 to 120 per minute. And at the same time, you should compress up to 5 centimeters. So depth of compression should be approximately around 5 centimeters. That's the standard depth of compression. And apart from that, you have the assessment of chest compression quality, which will be seen later on, not now. So now after completing once you're doing the CPR, let us assume your AED arrives. AED will arrive to the scene, which means till now, you have been in the basic life support only. Till this, you are in the BLS protocol. That's basic life support protocol, where you're doing only basic kind of a life support, which should be known by every single citizen, of course, in the country, to be honest. And now AED arrives. Once the AED arrives, you are basically entering the ACLS protocol, that is Advanced Cardiac Life Support Protocol. So once the AED arrives, the first thing is to do is you have to check the rhythm, what the rhythm is going on. There are 2 possible rhythms. One is shockable rhythm, or second is non-shockable rhythm. It could be shockable, or probably it could be a non-shockable rhythm. Shockable rhythms are basically only one thing. It is VT and VF. Since this VT does not have a pulse because the patient is in cardiac arrest, we call it as a pulseless VT. So VT with the pulse, we know how to deal. So suppose if they tell in exam specifically VT with a pulse, if they tell VT with a pulse, then you'll go for synchronous DC cardioversion only. Clear? Then that is different. If they tell you VT without a pulse, that is pulseless VT, then the patient is in cardiac arrest. So in this setting, VF will always be in cardiac arrest, I told you. So this setting, I have to go for urgent defibrillation. Urgent defibrillation, where I'll be typically doing something called an unsynchronized cardioversion. Here, there is no need of synchronization. What worse the patient can get? Already is in cardiac arrest. So there's no need to synchronize and waste time. So every 1 minute you waste time on defibrillating. If you don't give a shock, if you don't deliver a shock. Why they're told shockable? Because you can shock them. That's all. You're going to defibrillate. That's all. Defibrillation is also a type of shock only. What is the big deal in that? So you're going to do something called defibrillation or unsynchronized cardioversion. Straight away start with, and remember every minute you waste on delaying the defibrillation or shocking the patient, the chance of reverting the VT is going to come down by 5 to 10%. Within some 10 to 15 minutes, if you're not cardioverting, you may not be able to revert the patient at all. So that's why you should not waste any time. It's just as simple as that, as soon as possible. Don't waste time on anything. So you have to give defibrillation. That's what you're going to do. So remember, after defibrillation, you still have to continue CPR for 2 minutes. That's really important because it's a natural tendency to look at the monitor and wait for the sinus rhythm to come after doing a defibrillation. So don't do that, because there is something called post-cardiovascular stunning, where the ventricle would not have recovered properly even if the monitor shows the normal sinus rhythm. So still do CPR for 2 minutes and then you check the rhythm again. Check the rhythm again. In this setting, see where the patient is. If it's non-shockable, what is the examples of non-shockable rhythm? You have something called the pulseless electrical activity and you have something called asystole. So what do you mean by pulseless activity? Any other electrical activity apart from VTVF. Apart from VTVF, any other electrical activity without a pulse is called as pulseless electrical activity, and asystole means it's a flat line. That's asystole. So in this setting, they are non-shockable. You cannot shock them, and shock has not shown to prove any like good outcomes. So it's better straight away go for CPR into 2 minutes. You start with CPR for 2 minutes and then once again check the rhythm, and the whole cycle will continue. So depending on whether it's a shockable rhythm or not, because you have come back to this position, depending on whether it's a shockable rhythm or non-shockable rhythm, now you can continue the cycle again and again and again and again. And how long to continue the CPR? That's an ethical issue. Answer is, I don't know. I have no idea how long to continue CPR. It depends on your personal expertise, and no guideline can tell you have to stop the CPR at 20 minutes or you have to stop the CPR at 30 minutes. Nobody can tell that. It's your wish. How long you want to continue, you can continue. But guidelines are telling minimum you have to give 10 cycles of CPR, which means at least 20 minutes. This is the least minimum you have to try. Minimum number you have to try is 10 cycles or 20 minutes of CPR. But maximum how long? We don't know. PA is pulseless electrical activity. That's all. That is what we refer to as PA. And there are some things that you need to know. For example, you have certain drugs that you can use in CPR. And during the ACLS protocol, what are the drugs that you can really use is, number one, you have amiodarone. Let us see whether you use in shockable rhythms or not, whether you will use in non-shockable rhythms or not, whether what is the dose of the drug that you will use, and whether that can be repeated or not. Clear? So amiodarone, and you have lignocaine, not needed really, and you need to know about adrenaline. These are two drugs that you need to know. Amiodarone in shockable rhythms, yes. Non-shockable rhythms, no. You don't really use because there's no need of shock or any other cardioverting agents there. Dose is usually, starting dose is 300 milligram. Repeat dose, yes. You can give one dose, repeat at 150 milligram, half dose. After that, there is no evidence. And adrenaline, shockable, yes. Non-shockable, yes. Even though the evidence is more for non-shockable rhythms. Dose, you generally start with 1 milligram. That's a standard dose of adrenaline. That is 1:1000. 1 ml. That is, that's 1 ml only. 1 milligram means 1 ml only. And you are going to use IV. This is a standard dose of adrenaline in cardiac arrest. Repeat once again, yes. You can repeat every 3 to 5 minutes. Every 3 to 5 minutes you can repeat, which means you can repeat every, logically you can repeat every alternate cardiac cycle. Every alternate CPR cycle, you can keep repeating adrenaline, not a problem. So these are the drugs that you can use. And remember, currently things like intracardiac adrenaline is absolutely not indicated, because the reason why you give adrenaline is to increase the coronary perfusion, not to restart the heart. So it's a very bad idea that the students have adrenaline. If you give, it will restart the heart. No, we are not giving for that. We are actually giving adrenaline to increase the coronary perfusion, to maintain the coronary perfusion. So intracardiac adrenaline has literally no role for that. And it's not shown to, induce any good outcomes apart from injuring the patient. So many studies have shown against intracardiac adrenaline, and don't do that. And next is, what else? The doses are different for other conditions, which we'll discuss subsequently. And when you will give adrenaline and amiodarone? That's the question. At what point of CPR you will start? So you have to start adrenaline after the second shock. After the second shock, I can write here itself. It's better I will write here. So adrenaline, you're going to give for both shockable as well as non-shockable rhythms. If you are giving for shockable rhythms, in this setting, you will be starting after the second shock. After the second shock, But if you're using for non-shockable rhythms, then you will be starting immediately. So why is this discordance? Why it should be start after second shock? Because after the first shock, what you'll be doing? So before the first shock, what you'll be doing? Before the first shock, you'll be giving CPR. Okay. Your AED has come. You have checked the rhythm. It's shockable. The moment you know it's shockable, you're going to give the shock. So which means there is no point in doing anything before the shock. So, but after the first shock, you'll be free. So after the first shock, what you'll be doing? You'll be using IV line. You'll be trying top line IV line after the first shock, because the patient is not yet having the IV line, then only you can give the drug. So it takes at least 1 minute, isn't it? So once you have secured an IV line or 1 or 2 IV lines, then after the second shock, you give adrenaline. That is the idea. So if they ask you what you will do after the first shock, you will be busy in securing the IV line. Before the first shock, you don't know what's happening there. So you can't really do anything. So that's why if it's told you have to give after the second shock. They ask you when will you give amiodarone, because amiodarone anyway are not going to give in non-shockable rhythms. If you're giving shockable rhythms, when you will give, you will be giving after third shock. If somebody asks you what you will be doing after second shock, you have to tell I'll be busy giving adrenaline. Clear? So what you'll be doing after first shock, you will be busy securing an IV line. Before the first shock, you don't know what's happening. That's all. This is the idea. So these are the drugs that are used in the setting of a CPR. And at the same time, if somebody asks you what is the rescue breath, we told that the chest compressions has to be given at a rate of 100 to 120 per minute. If somebody asks you what is the rate, rescue breath rate. So what should be the rescue breath rate? What is the rationale? How much you have to give? Any idea? How much should be the rescue breath rate? Exactly 10 per minute. That's the rescue breath rate. It should not increase and it should not decrease. So if you give more, if you keep pressing the ambu more and more, the lungs will hyperinflate and it will compress the heart again, producing a tamponade kind of an effect. It's like a tension pneumothorax. If you give like 30, 40 and all, then what's the difference between you and tension pneumothorax? Both are doing the same thing, busy in killing the patient. So don't do that. Okay, sorry. I had got a message. Okay, 10 per minute. It should be exactly 10 per minute. That's what you're going to do. This is the rescue breath rate that you are going to follow. Then what else is there? Yeah. What is the best way to assess the efficacy of chest compression? Suppose if your chest compressions are the most important and they are good. So what is the efficacy of, how to check the efficacy of chest compressions? The efficacy of chest compressions can be assessed by doing an EtCO2, that is end-tidal carbon dioxide. My God, who's telling rib fracture? Efficacy of EtCO2, efficacy of chest compressions. If EtCO2 is going to be more than 10 millimeters of mercury, then that indicates a good quality CPR. Suppose if the EtCO2 is less than 10 millimeters of mercury, then it is sure that you have to try and improve the quality of the CPR. That's what you need to do. So EtCO2, if it's more than 10 millimeters of mercury, you have to, it is suggestive that you are having a good quality CPR. That's what it means. And apart from that, at the end of the CPR, you will be concluding that it's a successful CPR or a failed CPR. What do you mean by successful CPR? I call it as ROSC. That's called return of spontaneous circulation. ROSC stands for return of spontaneous circulation. That is what we refer to as ROSC. So once the patient has achieved ROSC, then next step is to give something called a post-ROSC care. You're going to do something called a post-ROSC care. EtCO2 was tracheal intubation, yes, after endotracheal intubation, or you can assess EtCO2 using your laryngeal mask airways also. There are a lot of provisions for that to assess EtCO2 using your LMS. So it's not like it's only endotracheal intubation. You can assess through a lot of basic, not basic, a lot of your lesser invasive endotracheal, lesser invasive airways like LMS also. What are the post-ROSC care that you have to give? In that setting, I'll be using ventilator. Of course, the patient will be in ventilator, so I have to go for some advanced this thing, ventilatory care. Ventilatory care. So as far as the ventilatory care is concerned, my tidal volume will be set at approximately 6 to 8 mL per kilogram. And usually my saturation can be set at more than 94. This is a target saturation I need to know. And apart from that, I can set a PaCO2 of approximately 40 to 45 millimeters of mercury. Based on this, I have to do some ventilation. Then there is something called a target organ perfusion. These are very important post-ROC care. That's called target organ perfusion. So this can be achieved by giving normal saline, plus or minus vasopressors like epinephrine or dopamine, or even you can give noradrenaline, or probably you can give even vasopressin also. Vasopressors. Then third is something called a very important one, that's called therapeutic hypothermia. You should have idea about what you mean by therapeutic hypothermia. So where I'm going to keep the body temperature at a range of around 32 to 36 degrees Celsius. This is not very difficult. You can achieve it very easily by infusing cold saline. All you need is only a tympanic membrane thermometer probe, and you need a cold saline. So by giving a controlled cold saline infusion, you can easily achieve 30 to 36 degrees Celsius. And what temperature exactly, we don't know. There's no difference in outcomes based on the temperature, but somewhere around 30 to 36 you can maintain. And this is one thing that definitely increases survival and has been proven by multiple trials. Yeah, to decrease the brain activity and to reduce the cerebral oxygen consumption. That is the main reason why we do that. So this is also referred to as targeted temperature management, TTM. So in exam, if they give something called a TTM, that is targeted temperature management, don't confuse with that. It's nothing but a therapeutic hypothermia only. So these are some post-ROC care. And failed means the patient is dead. You know, like it's deceased patient. So you're not going to do anything here. So you send to the mortuary. But apart from that, there are some indicators of poor neurological outcome. So you have to see the neurological outcome also. There are some patients who come out well, and there are some patients who don't really come out well. So there are some indicators of poor neurological outcome. So what are the indicators of poor neurological outcome? So remember, whatever test that you're going to use, what I'm going to tell now, it should be done only after 72 hours. You should not try to do within 72 hours. So which means you can correctly assess the neurological outcome by any technique. If you're going to use, you have to use only after 72 hours, not before 72 hours. So you can use a lot of clinical evidence. Number one, what are the clinical evidence to tell that the patient is not having any sufficient brain outcome to tell that the prognosis will be good? One is pupillary activity, absent pupillary response, and absent corneal or conjunctival reflex, even though corneal reflex is very important and more sensitive compared to the conjunctival reflex. And the patient is having continuous myoclonus, that is status myoclonicus. Continuous myoclonus jugs. Status myoclonicus, that is persisting for more than 40 to 72 hours. And absent motor activity. And the patient should not be in any muscle relaxants or sedation. So in that setting, if you call absent motor activity, then if the patient is having intractable status epilepticus, which means the patient is throwing seizures continuously in the continuous EEG monitoring. So these are some of the clinical indicators that the patient will not definitely recover. And we have some EEG evidence also. In the EEG, if you see something called bilateral absent SSEP, that's called somatosensory evoked potentials. If it's bilaterally absent, this is having the 100% specificity to tell that the patient won't recover. That's the only in fact which can tell with 100% certainty, 100% sensitivity. But unfortunately, the sensitivity is very poor, only 18 to 25. But specificity is excellent, 100% positive predictive value that the patient will not recover the neurological function properly. So bilateral absent SSEP. And apart from that, if the patient is showing something called a burst suppression pattern. Yes. Burst suppression pattern, that is suggestive of a poor outcome as well. And third, you can do imaging also. There are some imaging evidences are there. Like for example, if in CT, if you are seeing loss of gray-white differentiation, your gray matter and white matter look different if diffusely. SSEP stands for somatosensory evoked potentials. I told you already. So CT is loss of gray-white differentiation. If you have a loss of gray-white differentiation in CT scan, then that is also highly suggestive of poor outcome. You can assess this through MRI also by assessing certain lot of brain volumes and white matter and gray matter volumes and all. But then fine. And or not only this loss of gray-white differentiation, if you see extensive edema everywhere. So these are some indicators of poor neurological outcome. And suppose if the patient has gone for brain death, then that's a separate entity. We'll be discussing about brain death in the CNS section. So go for organ donation. It's better to move for organ donation in this setting. That's all. So this is how you manage the post-ROC patient. This is a post-ROC care that you have to give. In that, the predictors of neurological outcome are going to be really, really important. And in that especially, the burst suppression pattern has been asked many times and multiple times. They have not asked that bilateral SSEP absent, but burst suppression pattern has been asked many times. That's a very poor prognostic indicator. So will you do any advanced airway during the CPR? Advanced airway means we are talking about a laryngeal mask airway or endotracheal intubation. Answer is yes. And make sure that does not interrupt the chest compressions, because as I told you, chest compressions being the most important part of the CPR, make sure that the chest compressions are uninterrupted. So interruptions of the chest compression are associated with extremely poor prognosis. So at any point, make sure that the chest compressions are not interrupted. So which means while doing the chest compressions itself, even though you may not be able to intubate the patient, but you can use an LMA, laryngeal mask airway. So make sure that the chest compressions are not interrupted, even if you are using a advanced airway. So there are many types of LMA, especially with the modern types of LMA. You can directly intubate through the LMA. That's called, you don't use intubating LMA for that, but you can really use certain new LMAs like iGel and all, where you can directly intubate. So that's not a problem. And many times, these new modern LMAs facilitate some good, connection with the larynx. So usually you won't have any problem. So it's okay. So you can use a advanced airway at any stage, no problem. But provided, make sure that you don't really cause that much interruption in the chest. This is a very chest compression. This is a very common mistake that is done in the, Indian practice, because the moment the patient goes for cardiac arrest, rather than proceeding the CPR, they will go for intubation. So this is very, very bad. And anytime it will have extremely poor outcome. Many patients will not survive at all. That's the most important reason, in fact, that the patient don't survive. That is interruption of chest compression. Remember, in the United States, the overall number of patients that come to ROC after CPR is around 21%. But in India, the ratio is the numbers are very, very poor. It is 0.43%. These are the numbers in India. All these numbers tell that your CPR is extremely poor and inefficient, and you're delaying the chest compressions for a variety of reasons, and you're interrupting the chest compressions. And especially don't ask the one person to give chest compression. That should be a team. They should keep giving chest compression again and again. They should give in rotation, because you will get fatigue. Interruption means you stop chest compression. That's all. You don't give chest compression, stop for some time, for some reason. Very common reason in India is intubation. You intubate, stop the chest compressions during that time. That's bad. And that's why currently, chest compressions are given by some machines, automated machines, which can actually press the chest. The advantage of these machines is the fact that you don't get interruption at all, at any cost. And they're going to do correctly, unlike humans. And it's not going to get fatigued also. So to prevent the interruptions, you have some automated machines in US available. In India, it's not yet available, but they are good as well. Clear? And you're going to follow the standard airway maneuvers as well. At any point, whatever may be the point of your cardiac arrest management, you should always look for reversible causes, because there are many other causes that could be reversed completely. So for example, you have 5H and 5Ts. 5H and 5Ts. So what are the 5H and 5Ts? Basically, you have hypoxia, which can be reversed to an extent, and you have hypovolemia, which can be rapidly reversed by giving fluid boluses. And you have hydrogen ions, H+ ions, that is nothing but acidosis. You have hyponatremia, or hyperkalemia, hyperkalemia. Then you have hypothermia. All these things are potentially reversible, and in fact, many times they will give a very good outcome if you reverse them. Okay, many times they're going to give a very good outcome if you reverse them. And 5T stands for toxins, some drug poisoning. For example, if it's a TCA poisoning, then you can use soda bicarbonate that can rapidly reverse the arrhythmia. This is the best drug for treating a TCA toxicity. Amitriptyline or imipramine, like some drug like that. If you want to treat the toxicity, soda bicarbonate is the best for that kind of ventricular arrhythmias. Then you have a tension pneumothorax. Just by putting a needle, you can reverse it to an extent. Then you have a tamponade. Then you have a thrombosis of coronary. That is nothing but a myocardial infarction. You can do a PCI or you can go for a thrombolysis in that setting, but definitely I'll go for a PCI or thrombus of the pulmonary artery. That is nothing but a P, pulmonary embolism. So where I can reverse rapidly as well to an extent. So these are the reversible causes. You have to always look for the reversible causes whenever you wanted to, like treat them very rapidly. So if there are any reversible causes at any point, always treat them first. Otherwise, you'll have a poor outcome only. And finally, when you have to improve CPR, so which means when you mean that your CPR quality is not good. As I told you, if your EtCO2 is less than 10 millimeters of mercury, then it indicates that's a poor quality CPR. So you have to improve the CPR. Then if your relaxation pressure, this is nothing but diastolic pressure, which means when you compress the heart, you will result in systolic pressure. It's similar to systolic pressure, that's a compression pressure, and a relaxation pressure, that's a diastolic blood pressure, like that. So when you're doing a CPR, it's no longer systole, diastole, it's a compression pressure and a relaxation pressure. If your relaxation pressure is less than 20 millimeters of mercury in the monitoring, so that means it's a poor quality CPR and you have to improve the CPR, which means your compressions are not that great. And third, if your SpO2, that's mixed venous oxygen saturation, is less than 30%. And these are advanced, but usually we don't see. But most important is EtCO2 and this relaxation pressure can be very well seen. So if relaxation pressure is less than 20, EtCO2 less than 10, or if your mixed venous oxygen saturation is less than 30, then all this indicates a poor quality CPR. In that setting, you have to definitely improve the CPR quality. Then I told you ROSC. What are the signs of ROSC? ROSC means return of spontaneous circulation. How will you first of all know? How will you find out that the patient has gone for ROSC in the first place? How will you know that? To know it's an ROSC, there are certain areas. One is BP and pulse. You can look for the BP and pulse. The pulse comes back and the BP starts recording spontaneously. Then, of course, you can tell it's the successful CPR. It's a return of spontaneous circulation. But the gold standard is the EtCO2. EtCO2 is a gold standard. If there is a sudden rise in EtCO2 to more than 40 millimeters of mercury. So if this is the case, then it's the gold standard for assessing the ROC. For example, during CPR, it will be a flat line. Of course, EtCO2 will not show anything. It will be a flat line. During CPR, it will be something like this. Why? Because you are, not during CPR, during cardiac arrest. During cardiac arrest, it will be a flat EtCO2 and you won't see any waveforms. During CPR, you will be getting these small waveforms like this, but you don't get the normal waveform because you cannot do the function of a normal heart, how much ever you try. So you cannot reach the full form of EtCO2, but make sure that the height is more than at least 10 millimeters of mercury to tell it's a good quality CPR. Suddenly what will happen is at one point, there will be a massive rise. The EtCO2 will become more than 40 millimeters of mercury. So this is the point where you achieved ROSC for sure. So that's a gold standard. So that is return of spontaneous circulation. So that massive rise in EtCO2 is the gold standard. Apart from that, when you start seeing arterial line waveforms, if you have an arterial line or if you have a pulse oximeter, you are seeing arterial waveforms, pulse waveforms in the arterial recordings. So if you are able to see that, that again tells you that the patient has got a return of spontaneous circulation. That should be a typical arterial waveform like this. So this is arterial waveform. If you are doing CPR, it will be like this. That's not an arterial pulse waveform. I'm talking about the arterial pulse waveform. Pulse waveform, you know, what are the notches? If you have tidal wave, percussion wave, dichromatic notch, all these things should come back. So that's one side. But anyway, those are all having some pitfalls, but the best is always ETCO2. That's supposed to be the gold standard over here. These are ways to assess ROC, rate of spontaneous circulation. I think with this we have covered the CPR also. I think this must be enough for today. Where you have, I think you have learned a lot today. Hope. Compared to yesterday, we have picked up a little bit of pace today. So where you have learned a lot. So tomorrow we'll start at 10 o'clock. Hopefully my network is better tomorrow. So what I'm planning to do is I'm not planning to switch off anything here. So I'll just put the computer in this airplane mode and go. And the recordings for today's class, I think mornings and afternoons recording will be available by night mostly. But night's recording will be, I mean, this evening sessions recording will be available tomorrow only. We cannot do anything because to render to, I mean, to get that itself will take 2-3 hours, and to upload it definitely it will take another 3-4 hours. So tomorrow morning, maybe around 11 o'clock, 12 o'clock, your thing will have. Tomorrow I'll try to finish cardiology, then we'll start endocrinology. By I believe like I can finish faster tomorrow. Let us see, because today we have picked up a lot of pace. First day is full fun, only basics, nothing else. Second day, more information. Third, fourth day and all, you'll have more information. So only completely, you know, like exam oriented. First day is only usually I get oriented to you. That's the most important. Yeah, I'll share the EasyPD. Thank you. Good night. See you. Bye-bye.